All right, hello and welcome everyone. We are so excited you could all join us today. My name is Renee Caston and I am an undergraduate student here at Arizona State University. I am currently studying biomedical sciences and I will be your student moderator for today. Today we are going to be discussing COVID-19 101. This topic will cover the basics of the virus and everything you need to know to understand what exactly you have been reading and seeing online and in the news. Not everyone knows what mRNA is, how your body initiates an immune response, or even really how COVID is able to move and infect so easily. That is okay, and we encourage you all to write your questions in the Q&A box as they come up. We want to remind everyone today that science is an ever-evolving field. Many people are confused by new CDC recommendations and new findings, but we want to remind you all that new discoveries are made every single day, and the field of science, including COVID-19 discoveries, will keep evolving and progressing. Now, without further ado, I would like to introduce our speakers for the day. First, we have Dr. Erin Krasnow. Dr. Krasnow is an Associate Vice President for ASU Health Services and ASU Counseling Services. Next, we have Valerie Harris. Valerie is a clinical lab manager in ASU's Biodesign Institute and oversees the processing of over 42,000 COVID saliva samples every week. Next, we have Dr. Mario Islas. Dr. Islas is a family medicine board certified physician who is the current medical director of ASU Health Services. And finally, we will have Dr. Sarah Scott. Dr. Scott is a medical epidemiologist at Maricopa County Public Health here in Arizona. Again, we encourage you all to write your questions as they come up, and we hope you enjoy today's session. Dr. Krasnow, the floor is yours.
Thanks, Renee. Appreciate the invitation. Hello, everybody out there. Looking forward to your questions as they come up. I'll be brief. What we should start with is an acknowledgement of the impact of COVID-19 on all of our lives. There's not a human on the planet who has not been impacted in some ways. All of us have been impacted in one very similar ways, which is as humans, it makes us vulnerable to this virus. It means we can contract it. But so much about all of us in our individual lives makes us different in terms of the impact of COVID-19. Some of us have been individually affected. Maybe some of you out there or some of us on the panel have gotten sick with the virus or been infected and had no symptoms, which you'll get to in a little bit about what's so unique about this particular virus. Some of us may have had family members or friends be infected, get sick, get very ill, be disabled by, or perhaps have lost their life to this virus. Some communities have been impacted more significantly than others as a result of variables such as identities and demographics, living situations, economics. The virus has exposed a number of inequities in our local, national, and global society. People who are disproportionately affected include those who live in conditions that are marked by economic deprivation, historical health disparities. And so it's always important to remember that while this virus is equal opportunity and its potential to infect us as humans, it is having a drastically different impact on communities around the world. If you yourself have been directly impacted as an individual in terms of contracting the virus, someone close to you being infected, or very ill, or unfortunately passing away, know that this panel and myself have also had those experiences. There is nobody who, again, doesn't either know someone themselves, know someone close by who's had the devastating impacts of this virus. As a result of our knowledge about the virus and the emerging science that you heard from Renee, we've learned a lot very quickly about how to defeat it. And one of the things that we've learned about how to defeat it is it takes all of us to defeat it. It is not just the scientists who have developed the tests and the vaccines. It is also all of us as a society to band together to do the things that we know will limit the likelihood of the spread of the virus. And the spread of the virus is uniquely influenced by those behaviors. And so then when we as a society, whether that's an ASU society or Arizona or the United States or the planet, when we are all working together to maintain distance when possible, to wash our hands, to wear face coverings, to get the vaccine now that it's more readily available, then we got a better chance of limiting the likelihood of people being infected with COVID-19. When we don't, or only some of us do, all of us suffer. And so the thing we've learned over the past year is that so much effort, regardless of whether it's about mask wearing or hand washing or getting the vaccine, so much effort is about acknowledging and honoring and committing to doing the right thing as it relates to restricting the opportunities for the virus to infect other people. It's underlined the fact that all of us in global society are interconnected, something that was always true, but is now brought into sharp focus. And a lot of what you'll hear today in terms of the specifics about COVID-19, this COVID-19 101, I want to highlight that all of these things that are being talked about are only as good as our ability to work together, to take care of each other, to be responsible to each other, and to do the right thing. ASU's policies about mask wearing, about social distance on campus, recommendations on how to manage testing and vaccinations, all of that is designed to work with well-meaning, supportive community members like you. And so the fact that you've joined us today and to listen to this panel of experts talk about the specifics of COVID-19 is a great sign. And we just need you to take whatever it is that you learned today, or if we're just underlining things that you've already learned, take that to your friends and to your family members and remind them that we're a long way to go still to defeat this virus, but it is doable if we all do the right thing. So with that, I'm just thrilled that this is now a series. So thank you, Renee, for organizing that. Thank you again to all the attendees today. Thanks to the panelists. And I welcome your thoughts, and I'll turn it back to Renee.
Thank you, Dr. Krasnow. Now we introduce Valerie Harris. Valerie, the floor is all yours.
Hi, everybody. Thanks for having me here today to discuss COVID-19 with you. I'm kind of going to go over just a little bit of basics of, what is COVID-19? And we've all heard about this, and you're probably all bored to tears about hearing about what COVID-19 is. But I can also tell you a little bit about some different strains, and then also a little bit about how mRNA functions and actually how it functions in the context of the vaccine that a lot of people have been hearing about, and maybe some of you have received. So COVID-19 first was isolated in December 2019, in Wuhan, China, and it was actually found in people who patronized a wet market, and that's kind of an area where a lot of animals can tend to commingle with each other, animals of different species. And this is really important because generally in the wild, species on species interactions don't occur in really close proximity. But when you have a lot of different species kind of crammed into one smaller area, you can get a lot of interactions with animals that would normally never see each other in the wild. And there are actual animal viruses that can jump to humans, and COVID-19 is an example of one of these viruses. So that's called a zoonotic disease, meaning that it comes initially from an animal and then is transmissible to humans. As COVID-19 and the virus that causes it kind of spread throughout the world geographically, a lot of common mutations were picked up. Some mutations, conferred an advantage to the virus, maybe made it more transmissible, maybe made it a little bit more infectious. And those mutations, because they offered that advantage to the virus, naturally became more prevalent in the population. And so one of the ones that you may have heard of is it's called the UK variant, or B117. And these are, variants that have occurred for a lot of different reasons. Evolution is an extraordinarily complex thing, and especially when you're talking about viral evolution, things that take, species eons to evolve can happen very rapidly within viral evolution timelines. So a lot of these different mutations can arise and have different clinical consequences, but there are a lot of like monitoring for variants. CDC frequently updates their variants of concern. We also have variants of extreme consequence, which thankfully there are none of those yet. But the variants of concern are listed because they are slightly more, infectious or slightly more transmissible. So far, all of the variants pretty much are covered by the vaccine, which is great news. But we have one of the variants that I study frequently is called the UK variant. And we're actually able to detect it in our testing method because just by sheer luck, one of the mutations that is characteristic of B117 landed right within one of the regions of the viral genome that we look at. And so we can actually see that viral genome is significantly different than a standard COVID-19 infection. So we don't even actually have to sequence the sample. We can just kind of look at the results just as they are, as they come out of the machine. So that's kind of, covering a little bit of different strains. Another thing that I was asked to speak about was mRNA, and specifically how mRNA functions within the vaccines that a lot of you guys have been probably hearing a ton about. So mRNA is actually stands for messenger RNA. So in our bodies and in our cells, we have multiple different types of chemicals, I would say, that code for instructions to build proteins, or they code for, the instructions to make your eyes blue. It's kind of all of the different genetic code that you have is contained in something called a nucleic acid. And mRNA is one of these types of nucleic acids. And so how mRNA works is it's basically the instruction book for making proteins. So when you receive a vaccine that actually has just mRNA in it, which most of the vaccines are, Johnson & Johnson is a different modality, but if you receive an mRNA vaccine, you're not actually receiving the virus. So in the past, a lot of vaccines were, either a heat inactivated version of whatever the pathogen that was causing the illness was, or, maybe it was a super mild strain of whatever the illness was. But this is not either one of those mechanisms. It's actually just the instructions to build the proteins on just one part of the coronavirus. So coronaviruses look very similar to this guy in my background here. They have kind of a spiky envelope along the outside of them. And so this mRNA that's contained within these vaccines codes for just one little part of those spikes that are all over the virus membrane. And so what your body does when it sees this mRNA is it says, I've never seen this before, but I guess here are the instructions to make it. So your body then makes a bunch of those spike proteins, not the virus itself. It just makes the spike proteins. And then your immune system looks and sees your body making these spike proteins and says, I've never seen that before, but I guess, I'll watch out for it because you're making it. And so I'm going to develop antibodies to it. And so when you develop antibodies to those spike proteins, then when you actually experience a real coronavirus infection, your immune system will have already seen just those spike proteins. And so your immune system sees that and knows, okay, well, now we have to go over and, neutralize that, viral particle. And so that's actually how, kind of infection is prevented by getting vaccinated with an mRNA vaccine. But if there are any other questions that I can help answer, I'm happy to answer it, but I think that's pretty much all I have. I can turn it back over to you, Renee.
All right, well, I think we might have one question. We do have one question if you are answering it. So someone asked, so why does the vaccine cause side effects similar to COVID?
I'm also gonna let the people who have actual medical degrees answer this.
Okay.
But I'll take a blind stab at it, and Dr. Islas can correct me if I'm completely wrong. But when you have an infection, whether it's, when you have an infection, your body produces a reaction. You have inflammation, you have, the muscle soreness, the fatigue, because that's your immune system actually functioning. Your immune system is attacking the viral particle or the bacterial particle, whatever it is that's causing the infection. Your immune system is going after it, and you're experiencing inflammation as a side effect. You could also be experiencing, a fever because lots of different chemicals are getting released when your body is fighting an infection. When you are getting the vaccine, your immune system is still creating those antibodies. So it's still basically fighting an infection, but it's a very mild, I wouldn't even call it an infection. I would say that the best way to actually conceptualize it is that it's creating an immune response to that spike protein. So that's how you build those antibodies. But the spike protein can't replicate like a virus can. So you're not going to get the downstream consequences, for weeks on end that you would have if you had a natural COVID infection. If you get a vaccine related side effects, those are generally, 3 days max. Generally, they're about 1 day. So that's your immune system being triggered, your immune system activating itself as it would if you had a natural infection. But because you're not having anything that's replicating, it's not an actual infection. It's just your immune system being activated. So if you're getting a fever and you're getting sore after your vaccine, that's good. That means that you are mounting a successful immune response. And then I see that there's a follow-up question about why side effects are more common in Mrna versus Pfizer. I actually don't have information on that, and I won't speak to it because I would just be making something up on the spot. So I'll let Dr. Islas kind of address that one. So Renee, I can turn it back to you.
Yeah, thank you so much, Valerie. I think we can go ahead and turn it over to Dr. Islas.
Hi, everyone. How you doing? Yeah, first of all, the statistics or the details on the side effect profile of the different vaccines, it's very lucky that we have Dr. Scott here, who's an epidemiologist who could probably speak to the literal percentages a lot better than I can. Generally, what Valerie said was perfect. She said a lot of things that were exactly true, especially the fact that when your body revs up its immune system, no matter if it's from a vaccine or from a natural infection, then most of the time side effect profile is normal. And it's not a bad thing or a good thing. It just may be individually, that's kind of how it goes. The immune system being activated, people have different reactions, and some of them are normal. And one quick example, and I know this is nothing to do with what we're talking about, but a lot of times, so say someone has strep throat and they get swollen lymph nodes. Well, part of the immune system, the lymph node system are filters. So them revving up to be activated to go and start working and doing their job, that's normal, and that's a good thing. So it's not a bad thing in any way that someone has side effect profiles. And it is true that the majority are 1 to 3 days, if any. There are the majority of people that have very low or none. And I would caution people to say, well, if I don't get side effects, does that mean I didn't respond? Because that's not true. Everybody's individually of how they produce things. So hopefully that answers that piece. The subject that I was going to comment on generally that I was asked was to basically see how your body reacts to COVID. Well, just to backtrack a bit, I wanted to just make sure everyone knows how COVID enters the body. I know that people have a lot of assumptions, and that's great, but the literal way is very simple. You have someone with COVID that has either a respiratory droplet that is spewed out. So either from a cough, a sneeze, or something like that, and then it enters through the nose, the eyes, or the mouth. That SARS-CoV-2 virus will then travel down, and it will usually replicate because it is taken into cells a lot into the lower respiratory tract, but it can be other places in the body as well. And the mechanism for that, really, you have a receptor on a healthy cell, and that receptor does bind to one of the spike proteins. And the spike proteins are the little nubbies on top of the coronavirus. And then it is transported into the cell. And after it's in the cell, in a healthy cell, it will commandeer the healthy cell's mechanisms to make copies. And that machinery, with reproducing the RNA and the proteins for packaging, it's a normal process with most viruses. It's nothing surprising of how that mechanism happens. It's just the ability for it to happen in different ways in different people. That's not so much typical. The predictability is really unknown. So that being said, the infected cells, they reproduce, hundreds to thousands of copies, and that can spread throughout the body, and then the cycle repeats over and over again as those viral particles will spread. So there are main systems that COVID-19 will affect, primarily being the lungs. As we all know, it's a respiratory infection for the most part, but it can affect other parts of the body too, and other systems. On the lung side, it usually travels deeper than a cold. I mean, coronaviruses are also cold viruses, but when that travels deep, you have an inflammatory response. It can make it tough for you to breathe. It can lead to pneumonias or other deep infections. The cells in the body that help the oxygenation, the alveoli, they can get leaky, fill with fluid. You can have damaged cells, make it even more difficult to breathe, and that oxygen exchange just becomes more and more difficult. If oxygen is not adequate, of course, then you will need oxygen support. If it's still low, then that would require more support with pressure. Something called BiPAP is usually the next thing after just regular oxygen on you. And BiPAP is basically a pressure mask that allows for you to have a little more intense support. And then if it still doesn't go where your oxygenation is well enough, then eventually you may require ventilator support. Now, who gets sick and who doesn't, we don't know. I mean, there's lots of theories about who and why, but generally all the pieces about having pre-existing conditions or things of where you start as baseline, those play into it as well. The other piece that I was going to tell you, a lot of times people will assume it's mostly respiratory, but there are other systems involved also. You have the inflammatory response, and that inflammatory response where it is natural for the body to react to things. Sometimes in folks with COVID, it just goes haywire. It's just not regulated. So, for example, the receptor on a healthy cell, this ACE2 receptor, in some people, it is it's bound because there's so much COVID around. So if ACE2 helps inflammatory responses to be regulated and that's bound, then that may be one of the mechanisms. Some of these things are theories, but some of them are kind of known and being worked on with research now. There is something called cytokines, and cytokines basically are an inflammatory response, and they're individually named. There's a list of them, truthfully, and when those get released, sometimes you have to the point where they go to all be released all at once or in a very short time. there's something called Cytokine Storm. And what happens with that is if you have those all released at once, then the purpose is to recruit more immune cells, but if it goes unregulated, then it's just a mess. So you kind of have your immune system going way on overkill, and more things are causing inflammation, which is not good. If you have more inflammation, especially from this type of mechanism with cytokine storm, then you get more tissue damage and more leaking and tougher oxygenation and other parts too. Another system that is affected, not as often, but often enough that it's very well known now, is the cardiac system and the vascular effects. Well, those inflammatory responses sometimes cause myocarditis, which is an inflammation of the heart muscle. That's even seen sometimes, even if you're a few months out. It is an association, but the how common it is really up in the air, mainly because we don't check for this unless there are problems. There are some people with COVID who have are young, healthy people that have this also, and there's not any real predictability to that. If your heart muscle is affected or weakened or becomes irritable, then that can lead to arrhythmias also, where the heart rhythm just is not normal or not in sync. So things like atrial fibrillation, things like that can cause increased risk for clotting or strokes. And then also the heart rhythm problems can also cause heart attacks too. So the heart effects are possible too. There are kidney effects also with COVID, and the kidney effects, you can get an acute kidney injury with COVID. Those may be related to where you started with your kidney function as a baseline. So like, for example, if you have diabetes and you already have a stressed kidney anyway because of a long chronic history of that, then that may lead to you being more sensitive to those possibly. In the ICU, I think it's usually documented about up to 30% of the ICU folks will require some kidney support, including dialysis sometimes. But like I said, that may depend on where they started from. Recently, there's been more evidence that some of the viral particles are found in the kidney. So it's not known at this point. One of the last things I was going to talk about is the nervous system. Well, the nervous system effects they're very interesting, and they're very strange, like the loss of taste and smell, or headaches, or fatigue, or weakness. A lot of those things. There are many people who have these, and sometimes at a low level that you get recovery in 2 weeks or so, and that's fine. And other people, there are long-term effects with some of these. Those mechanisms are not really known. One thing that is often stated is because COVID is in the respiratory tract and enters through the nose, some of the nerve system that is very close with your taste and smell going up to the brain, they're in close proximity. So it may be that that's why it's an early sign in some people, but that overall, that's not known. I think that's pretty much all I had, and I will be open for questions also.
Thank you, Dr. Islas. I think we will have a Q&A session after Dr. Sarah Scott discusses. So I believe we can answer all the questions that we've gotten then as well.
Sure.
Okay. So now we're going to have Dr. Sarah Scott. Dr. Scott, the floor is all yours.
Okay, let me try and get PowerPoint up here so I can share my screen with you guys. Okay, are you able to see that?
Yes, looks good.
Okay, great, thanks. So my name is Sarah Scott. I'm a medical epidemiologist at Maricopa County Public Health. I'm trained as a doctor in internal medicine and pediatrics, and then went into the public health field. So I was asked to talk about kind of epidemiology and what is that, and kind of why does it matter, especially in the setting of a pandemic. So epidemiology, I feel like, is a word that we've heard more and more frequently in the last year than maybe ever before. But I think the real question is, what is it? What does that mean? And why should we care about it? So formally, by definition, epidemiology is the study of the distribution and determinants of health-related states and events in specified populations. So that is clearly the official definition, but again, what does that really mean at the end of the day? So it's the science of how we use data to find out who is affected and the causes of disease on a population level. So with COVID-19, for example, that means using data to figure out who's getting sick. Is it mostly men? Is it old people, young people? What about people of color? Is it clustering in certain areas of the county? And what about schools? There are people who live in congregate living facilities. And what about the college students, living on or off campus? So all of those are questions that we use epidemiology to try to help answer. So to literally break down the word epidemiology, it's the study of what is happening to the people. How's that different from, say, a doctor or a nurse who's practicing clinical medicine? And I will admit it took me quite a while to really kind of understand conceptually how this is different. So a doctor practicing clinical medicine is thinking about that one patient, that one person sitting in front of them, thinking about how they got sick, what is the illness that they have, and how do I treat this person who's literally in my office. Whereas epidemiology is like thinking about a whole population as your patient. So we think about, why are people in Maricopa County getting COVID-19 maybe more than people in Gila County, for example? Does one part of Maricopa County not have enough COVID-19 testing? What can we tell the folks at ASU about how often college-age people are getting COVID-19, and how does that compare to maybe what they're seeing on campus? So trying to conceptually think about one person versus a population level. So how does public health find out what's going on in Maricopa County? It's not like everybody who has COVID-19 is calling us up to tell us that they have COVID-19, although sometimes it feels that way. Believe it or not, people like healthcare providers are required in Arizona Administrative Code, which is basically state law, to report cases of a list of more than 100 diseases and conditions to public health, and that includes things like COVID-19. It also includes things you've maybe never heard of, like chikungunya virus, and things you're probably more familiar with, like HIV or Zika. The groups of people who report to public health are called mandated reporters, and that includes, but isn't fully limited to, healthcare providers and clinical laboratories like ASU Biodesign, as well as other places where more vulnerable people kind of gather together. So schools and childcare facilities, nursing homes, and correctional facilities. This process is similar, but not necessarily identical in every state. So all that data flows into our Arizona kind of statewide reportable conditions database. That means that we at the county health department get reports for every positive COVID-19 case or laboratory in a Maricopa County resident. We use that information to reach out to every person who's tested positive for COVID and conduct a public health investigation, which is really, at the end of the day, a fancy way of saying that we call you up and ask you a list of questions to try to understand kind of what kinds of symptoms you might have had, whether you were hospitalized, whether you live or work in a setting with people who are at high risk of getting really sick from COVID and things like that. All the data from each investigation is gathered into our database. It's lumped together. It's analyzed by our epidemiologists using this fancy SAS code that is like gibberish to me, and used to produce data reports for the public and our public health team. So we post updated data online daily, so you can see how many people are testing positive for COVID each day. You can see how many cases fall into different age groups and see how those have differed kind of throughout this pandemic. You can see what populations become sickest or even die from COVID-19. And we also use these data to understand what parts of the county are most impacted. So kind of bringing us back full circle to what is epidemiology. In the case of COVID-19, we use that data and epidemiology to understand who gets infected, who has more severe illness, who's more likely to die, and who's disproportionately impacted. And ultimately, we use those findings to help inform population level policies, things like mask mandates, things like county level policies, state level policies. We use that to try to target education to the appropriate populations, and also think about how to get vaccine to our most vulnerable populations. So that is kind of the 1,000-foot view on epidemiology. And if you have any questions or are curious about our publicly available data, I guess you can't click the links here, but I am happy to share these slides with you guys. And I know that, let me get back to Zoom. I know there was at least one question about vaccine side effects that I wanted to show you guys. So I should still be showing you my my main screen here. Are you guys seeing the side effect thing? Sorry, I'm having trouble using Zoom right now for some reason.
Yes, we are, Dr. Scott.
Great, thanks. So this is a slide from a talk that we gave to some healthcare providers. Basically, this is showing you that out of all people who were in the trials for the different types of vaccines that are currently under EUA authorization in the United States, so Pfizer, Moderna, and the Johnson & Johnson vaccine, what percentage of those people experience different types of side effects. So you can see those blue and red bars are our Pfizer and Moderna vaccines. Those are our mRNA vaccines. And together they have actually fairly similar side effect profiles. So while yes, this blue Pfizer bar is a little bit lower than this red Moderna bar, 85% compared to 90% is really pretty much the same when you think about it in terms of a group of 10 people, 8 or 9 people are going to have, injection site reactions. So thinking about it that way, the mRNA vaccines really have kind of similar side effect profiles, but that Johnson & Johnson vaccine seems to have less side effects overall than the mRNA vaccine, which then leading into a second question was, why is that? I don't think we know exactly. So the mRNA vaccine is a new type of vaccine technology, and it is clearly proven to be able to produce a really tremendously effective vaccine, and with that, produce a really good immune response in people, which are the side effects that you're getting. I suspect at the end of the day, we'll understand more about how those different, how the functionalities of those vaccines or their technologies, probably the side effect profiles are going to come down to that. So while Johnson & Johnson is maybe a little bit less effective in terms of preventing kind of like mild COVID, that is likely also due to the formulation and has and probably also falls in line with the side effect profile. So I think there's a lot more data to be kind of gathered from that though before anybody makes any kind of definitive conclusions. Let's see, what other questions can I answer? There's another one that was on vaccine side effects that was talking about a person who had COVID earlier on this year and then got the vaccine recently, got side effects after experiencing that, after having that vaccine, and what does that mean for the second dose? Will that person have more or less side effects? So we have seen that people who have been infected with COVID previously tend to get more side effects with that first dose of vaccine, probably because your immune system already recognizes that spike protein as being something that's foreign to it and that it wants to fight off. In general, there's no set rule on who's going to get side effects with that second dose, but I think generally it's safe to say if you had side effects with the first dose, you will probably experience them with the second dose, and just to kind of mentally prepare for that. But I keep telling people when I see them individually to think about that as, the vaccine really working. That's your immune system really recognizing that spike protein as being foreign and doing its job. Sometimes playing, that little mental trick on yourself can make it feel a little better when you're feeling kind of crummy. Let's see, Philip, do you want me to keep going on answering questions, or let me know how you want me to proceed here?
So Renee, if you want to jump back on and you can guide us all through a Q&A session, that would be wonderful.
Yeah, so I think we can go ahead and jump into the Q&A, and then whoever feels most fit to answer the question, just hop on. Also, for all of our participants and attendees today, you can also use the raise hand function, and we can also allow you to talk if you so choose instead of using the Q&A or chat function. So we do have a question that says, is it safe for me to only have my first vaccine and travel to visit my mother who is 84? She is vaccinated. What are your thoughts?
I feel like that's coming to me, unless Dr. Eastless, you want to fight me for it.
It's all the time, every week. So, but you're perfect to answer this.
Okay, so the word safe is to tell you whether or not it's safe requires me to have a little bit of a crystal ball, which unfortunately broke sometime last year around the beginning of COVID. Because I get what you're asking. Am I going to get my older mother sick? And we know that finishing the vaccine series and being 2 weeks out from finishing that series is going to get you to the point where you have maximum immunity. So really the safest decision you could make would be to complete a series. So that's either 1 dose of Johnson & Johnson or 2 doses of Pfizer or Moderna. And then 2 weeks after that, we know that your immune system will have kind of mounted a full response to that vaccine. So that's your safest bet. I would say if your mother is fully vaccinated, CDC does say that even one household that is not fully vaccinated is okay to visit another household that is fully vaccinated. So certainly doing that is well within CDC guidelines. I think it is okay to do that, but know that there's kind of optimal, and then there's like pretty good. And I think you're in a pretty good spot, but fully vaccinated is best.
One other thing, if I can add to, with this last set of CDC guidelines that changed to allow more interaction after vaccine, well, that's all true, and Dr. Scott is exactly right. But one thing they didn't change is actually the travel guidance. So it'd be one thing if you're going across town to visit your mom or grandma. But if you're going to be traveling in an airport, on a plane, in crowds, of course, you're still going to do your mitigation measures, but that's probably more of the risk when it comes down to it. So just add in that the travel guidance wasn't really changed with this last set of recommendations.
Amazing. Thank you both. I think we can go ahead and move on to the next question here. I think we have Why do you think the mRNA vaccines like Moderna and Pfizer seem to be better for protection as compared to other vaccines like the Johnson & Johnson?
That back to me. I think that's a good question. I think this has really been to see two brand new vaccines using brand new technology like these mRNA vaccines, and to see their effectiveness be 90–95% is incredible. And I think anybody who studies vaccines and kind of immune response was blown away by that. So I think we're really happy to see that we can really trigger a good immune response using that technology. I still think we probably don't know exactly why the spike proteins that your body develops from those mRNA vaccines, why that seems to be a little bit more effective or a little bit more robust of immune response than the Johnson & Johnson technology. And I should be clear and say that it's nothing against Johnson & Johnson. Also, fantastic vaccine, just a little bit different in terms of the mechanism of how it triggers your body's immune response.
And one thing to add too, just to remember what is typical for a good vaccine. For example, most years, if you have a flu vaccine that is in the 40% effectiveness range, it's considered a pretty good year, and it's a really good vaccine. So when it comes down to 67% or 95%, those are really, really good either way. The other thing to remember too is, all these didn't come out at the same time. So on the data side, there were different sets of circumstances with how things were even done with the testing pool and possibility of more variants later, and also on the piece of how the timing just goes. So if they were all put on a race and say, okay, October of 2020, we have 3 and we're all going to test them with the same pool, then the one-to-one comparison is easy, but it's never going to be that way. So overall, they're all very good.
And I think one key that is maybe missed a little bit in the kind of public messaging through media and things like that, we're talking about this one being more effective than that one, and on and on and on. It's really important to look at the trial data and say, what outcome are we talking about preventing with what vaccine, right? And the real key here is to say, each of the 3 vaccines is almost 100% effective at preventing people from getting hospitalized and from dying from COVID-19. That's the key takeaway, right? Might you still get a mild illness after being vaccinated? Sure, that's possible, and that might vary a little bit from vaccine to vaccine, but all of them are incredibly effective at preventing the severe outcomes. And it's way more of a spectrum of gray than kind of black and white is how I think we're hearing about it.
All right, thank you both. We have another question. I've heard rumors that how bad your vaccine side effects are correlated to how bad you would have had COVID. Is there any truth to this?
Dr. Eastless?
So I don't know if that's known. It's one of those theoretical things that people would make a lot of assumptions, and I don't know if that's really fair, because it's a lot of assumptions that you could go down a whole rabbit trail to say that means something. Individually, someone's response, whether it's to COVID itself, getting where there's no symptoms at all, or having a vaccine that gives you a few layers of side effects, or some that get none, it's individually, those are just really important to kind of take heart, to say my decision making on whether to do something with my behavior or my intention to be vaccinated or to behave a certain way, things like that. Those are all going to be based on different priorities for people. And I think there's really no reason to put layers of assumptions in there. It just use what you need to use to make good decisions for yourself and for the people around you. And that's what it comes down to. All the data pieces in time will come out, but this has only been around a year. A lot of times, 4 or 5 years down the line, we'll have known a lot of these trends to be giving us those answers, but right now we just don't have them.
All right. So next we have another question. When do you think we'll know how long the vaccine immunity lasts?
So I think, like, Dr. Easels alluded to, we only know what we know since the vaccine came out, right? The people who have been vaccinated longest have been the people who were a part of that clinical trial. And they will continue to get follow-up, I want to say for, can't remember if it's 3 to 5 years after that initial vaccine, but really that's going to be the first wave of people that's always telling us, how well are their antibody titers and other kind of immune system measurements functioning against COVID. So, we'll learn more as each 3, 6, 12-month period passes. So we don't know, but hopefully a long time.
All right, and we have one more question in the Q&A box. So if any of you have any questions you would like to ask, please type them now so we can get to them. But other than that, we have one final question, and I think, Valerie, you would like to answer this as well, is how accurate are the COVID tests? Do we know the statistics on false negatives?
Yeah, so this is an interesting question because it contains a lot of layers. So there's multiple different types of COVID tests that you can receive. A lot of people think that the different types are whether you have to get something up your nose or whether you spit in a tube, but that's not actually, those are differences, but there's also differences in what the test is actually detecting. So our test at ASU, and I can speak to, the ASU perspective, is testing for the nucleic acids that are contained within that SARS-CoV-2 viral particle. And so we basically take all of the nucleic acids in all of your sample when you spit in that tube, and we extract them and then concentrate them back down. And then we are actually able to look for SARS-CoV-2 RNA within that sample, and we test for 3 different viral genes. So there's a lot of different tests that test for different numbers of genes. The Cdc Assay, which is another test that you'll hear thrown around, that one tests for 2 viral genes. Ours is actually 3 different parts of the viral genome. So we can look at, what's called an open reading frame, which is just a general segment of the coding area of the genome. We can look for the N gene is another one that we look at, and then the S gene, which is that actual spike protein that's covering the membrane of the coronavirus. So because we look for 3 genes, the likelihood that you're only going to test positive in one of those genes is very low. If you test positive for 2 of those genes, well, then we're going to, we retest the samples basically, and we don't make our decision based on a borderline case. If something is borderline, we're going to either retest it or ask you, if you've ever gotten an invalid. A lot of the times that's what's happening. It doesn't mean that you did have COVID, it doesn't mean that you didn't have COVID, it just means we can't tell, and we're not going to give you a false positive or a false negative. False negatives are also more prevalent the more people that are getting tested. So as testing increases, the chance that a false negative could occur is increased. But all of the assays that are used within ASU have been validated through the FDA, and they have been validated multiple times within the lab that's actually running the test. So false negatives are pretty uncommon. Same thing with false positives. We get a lot of people who are asymptomatic for COVID, but they say, oh no, but it's a false positive. And then we retest another sample that they provided. This is not a false positive. You actually have COVID. So there is a lot of validation and making sure that the results that we're giving out to people are correct. Now there's other types of COVID tests that you can get. And so some of the ones that you can get in like 15 minutes, those are called a rapid antigen test. And so that's not actually looking for nucleic acids, that's actually looking for proteins that belong to the SARS-CoV-2 virus. And those ones I would say don't work as well. So you're more likely to get, I would say, a false negative on those because they're not very good at asymptomatic screening. So they were never really intended for that. They were intended for a point of care diagnostic that if you are already exhibiting the symptoms of COVID, you'll test positive, and we can differentiate it between COVID and some other type of upper respiratory infection. But they are not meant for general screening purposes. So anytime anybody asks, what COVID test should I get, I always recommend that they get a nucleic acid amplification test, which is this, the qPCR test that ASU provides. A lot of other clinics provide it as well, but those are the ones that, if you have to travel, like you have a family emergency and you absolutely have to travel, those are the ones that like international airports will accept. But antigen testing, I personally don't believe that it is a super great way of population screening. It's very convenient, but I wouldn't sacrifice convenience over accuracy. And I don't know if there's anything anybody else wants to add to that.
All right, well, if there are no more questions and none of our panelists want to add anything, I wanted to go ahead and say thank you to all of our participants today, attendees and panelists. None of this would have been able to happen without any of you, and I am very appreciative. And I, first of all, wanted to say thank you. Secondly, wanted to remind you all who attended that we do have another one of these next week at the same time. It will be the same link that you all clicked on today. Next week, our topic is COVID, the impact on our businesses and environment. Now, this is going to discuss kind of ASU's innovative way of handling supply chain and management during the whole pandemic, understanding what this has done to all of us on a business level rather than a health and cellular level. So we hope you can all attend that. We also will have different speakers next week, and we encourage you all, if you enjoyed this, to share it with your friends, family, anyone who has any questions about COVID. We definitely encourage them to come. And we are just excited, and thank you all for coming again, and thank you to our wonderful panelists, and we hope you all stay safe and healthy. All right, hello and welcome everyone to our COVID-19 speakers series. We are so excited you could join us today. My name is Renee Kasten, and I am an undergraduate student at Arizona State studying biomedical sciences, and I will be your student moderator for today. Today is our second week of our 4-week-long speaker series, and our topic today is COVID, the impact on our businesses and environment. We've all heard a lot about the effects of COVID inside the body, but what about outside the body? Have you ever thought about how supply chain is affected during a pandemic, or even what about the overwhelming amount of waste that has impacted our environment during this pandemic as well? Well, you are in the right place, and we will be discussing all of that and the effects that has had on our planet and our businesses. We encourage you all to write your questions in the Q&A box as they come up, and we will then answer these questions towards the end of the webinar today. We also want to remind everyone today that science is an ever-evolving field. We as people are so used to being able to Google something and you get the answer right away. And it's kind of shocking to live in a world where that, isn't the case, and we don't know everything about COVID. However, I want to remind you all that experts around the world are working endlessly and tirelessly to find the answers to your questions. And we are fortunate enough to have 5 of those experts with us today. And I just want to remind everyone, research is a process and understanding COVID and its effects is a process. And it is a very unique and fortunate opportunity that we are able to see it in real time today. Now, without further ado, I will introduce our speakers who will discuss the overall, our first speaker who will discuss the overall scale and operations of our COVID mission at Arizona State University. We are having a couple of technical difficulties on the back end of things trying to get videos started. So you may only see her picture, but we have Mrna Dwyer.
Thank you, Renee, and thanks everybody for participating. So yes, I'm Mrna Dwyer. I'm the Chief Operating Officer of the Knowledge Enterprise at ASU. And we have been at the forefront of dealing with the COVID pandemic here at the university and actually in the state of Arizona. So I'm just going to talk a little bit about the various activities and then sort of how those translate into the business of the university. So as many of you are aware, we and the Biodesign Institute, which is part of the Knowledge Enterprise, have been operating the COVID testing lab, the ASU Biodesign Clinical Testing Lab. So that's been providing all of the testing for the not only the ASU community, but also a number of partners and the general public. So in terms of the scale and scope, we are now approaching 800,000 tests that have been done for all the various communities that we support. And so that gives you an idea of scale of the operation. In January alone, we ran 133 separate testing events for the general public. And that's in addition to all of the testing that's going on at the university. And so a couple things that come out of that from this standpoint of, again, scale of operations is it gives us the opportunity to build relationships with partners. And so many of the partners that we're supporting are organizations that the university has worked with for many years. And this allows us to both help them with business continuity for what the services that they provide, but also to build partnerships and strengthen partnerships. So we're very grateful for the opportunity to work with those partners at scale. And so I think those will translate into ongoing partnerships, with critical infrastructure companies in the Valley and things like that. So in addition to that, the lab itself is a new asset to the university. So we were not previous to COVID actually providing clinical testing to the community. And so that actually is a new asset to the business of doing research at the university because clinical samples, doing work directly with patients and the community is actually a tremendous asset to be able to advance clinical research at the university. And so of the nearly 800,000 tests we've performed, we've had 90,000 participants engage with us and agree that they would participate in research at the university moving forward. And so we're excited about all of the new, even non-COVID related relationships that's going to help the university build. And so, when you are building the research enterprise at a R1 university like Arizona State, it's obviously starts with faculty and students and all of the expertise and ideas that they bring to the table, but also all of these other assets that help them get the work done and create the discoveries that we're all dependent on. So I have a little pin that I got from a friend that says, thanks science for the vaccines that we're all working on distributing. And so we're excited to advance that type of research at the university beyond COVID as well. And then finally, to give you an idea of the biggest operation that we're running as part of the COVID response in the community is actually the state vaccination sites. So we stepped in at the request of the Arizona Department of Health Services I think we had 6 days. So the team out there really worked miracles. So we stood up the 24-hour-a-day vaccination site at the State Farm Stadium. It became operational January 11th. We've since added the Phoenix Muni location to that program beginning February 1st. And so that is, coming up out of the ground with an operation that requires about 500 people a day to operate. So between mission critical staff and volunteers and, the various folks that are out there waving flags around and helping cars get through the site. And so really just ASU's experience at building things at scale, I think that's given us an unprecedented experience in the community and also let all of our partners in the community know what we're capable of. So we are very excited, again, back to things that we can do moving forward, to be known as a partner to all of these agencies in the state that could literally in 6 days start from nothing and build a 500 per day person operation that's doing 12,000 vaccinations every 24 hours. One vaccination is administered out there every 10 seconds. So those are pretty incredible accomplishments. And as many of you may know, we did have a visit from the president, a virtual visit from the president of the United States and the vice president as well, looking at what we've done and trying to share those best practices. So that is just sort of a brief overview of the scale and scope of the operations that we have done on behalf of both the university and the community writ large. And so excited to not only continue those efforts, but also look at ways that we can leverage that moving forward for the university. With that, I'll stop and turn it back over to you, Renee.
Thank you so much for that insight. I am very excited to be a part of the State Farm vaccination site on Friday. I'm getting my vaccine, so we're all very excited. So we are now going to introduce our second speaker for the day, who will shed some light on the effects of waste from COVID-19 and how that has impacted our environment. So without further ado, we will introduce Michael Oakes.
All right, well, thank you. Hi, my name is Michael Lopes. I'm with our Environmental Health and Safety Department. So our department supports all the university sites, and what we primarily do when it comes to COVID is a number of things. And that is, we are operating the testing sites where people and students and faculty and community go and get tested for COVID. We also operate the vaccine sites. So with that, I'll just give you some information about our department. We have about 35 to 40 employees in our department. And when COVID started, we realized there's no way that with 30 to 40 employees, we could continue to support these testing sites at that time. So during that time, since basically March of 2020, we had hired 90 staff members at the testing sites. And we also had over 600 nursing students volunteer their time at those testing sites from ASU nursing students. And you notice all the masks that they wear at the testing sites. So we had to perform tests for employees and volunteers to wear those masks. And we tested over 700 people to wear the masks. And the purpose of those masks is, one, to protect anyone coming in, from COVID, and also vice versa, if someone coming in, unfortunately positive, we're not aware of it. I can't even tell you the number of hours put into these sites, over this past year. We've been talking about tracking it, and I couldn't even attempt to tell you the number of hours all these employees and volunteers have put in. But during that time, we operated 3 drive-through sites where people could drive their car through, get a test done, and I'm sure people on this call have done that. We also operated 4 indoor testing sites on the campuses where people can walk through a line, get the test done, and then receive the results later. What's interesting, all those results are actually analyzed, but what was mentioned earlier with the biodesign at the testing lab there. So we also started pulling back some of those sites, because when the Devil's Drop-Off program began, we decided there wasn't as much of a need for the testing sites when employees, students, and community could perform the test themselves and then drop it off at our stations across campus. So with that, some of the numbers I've seen since June of 2020 through February of this year, there's been over 224,000 tests collected. So you think that's quite an event, and that we're operating and supporting. So another aspect of this is the waste. And I think you mentioned that earlier, like how's the waste being handled with this situation? So our department has a team of 5 members who handle all hazardous waste for ASU. And to give you some perspective on typical waste content, when it comes to biological waste, prior to COVID, we would collect around 10 to 14,000 pounds per month of biological waste. And that primarily comes from our research labs who are performing the research. When COVID started, we noticed a significant drop off around March or April of 2020, where we were down to about 8,000 pounds per month of waste. So for about 4 months during the summer of last year, we saw a significant drop off in the amount of waste. However, when all the testing began and all the aspects of that, we saw a significant increase then back up to our typical numbers, around 15,000 pounds per month of biological waste that we would collect and manage. So since that time, we've seen a steady, volume of waste that we're managing. So obviously COVID waste, I would say probably from the beginning when we started to handle COVID waste to now, it's about we've increased our waste stream about 4 times based on the COVID generated waste, caused by all this testing that we're doing, which it's part of doing business, and we're trying to find ways to manage it the best that we can. What we also found we needed to do is we partnered with another local company called Care Environmental Services, and we have 2 full-time staff members helping to handle the collection sites for all the waste that is generated, by us testing. So that gives you some perspective of what ASU, our Environmental Health Department, does when it comes to COVID, managing the sites, the waste involved. But then also on top of that, we had to perform what's called site assessments. So if there's ever going to be an event or some type of activity on campus, one of our staff members would go assess the site to make sure that the site was set up, to keep social distancing and masks in place. And we estimated we performed probably about 400 of those site assessments over this 2020. So that's another aspect of the business perspective of COVID when it comes to our department. And I noticed there was a question that came out in advance asking about waste. And it wasn't so much the biological waste, but just how is the waste generated from food handling and other waste on campus when we don't have our cafeterias open. So I reached out to what's called Zero Waste, which is a zero waste management team on campus. And what they mentioned to me, which was interesting, they've actually been tracking the amount of just general waste that's generated during COVID and prior to COVID. And what they found actually was we're actually producing less overall waste, solid waste is what it's called, that goes to landfills. And that's your typical trash cans. We're actually producing significant decrease just because the less students on campus, and also the cafeteria is not being open. And one thing that they're trying to work on now is trying to work with Airmark, which is our food handling provider, to figure out more to-go containers or reusable containers that could also reduce the waste. Because I think there's a lot of people that, they just have concerns that they don't want to maybe use a reusable container for their food, and like in a typical cafeteria that's cleaned and washed, just because of concerns of contamination. So right now, the Zero Waste Group is working on education campaigns with Airmark to find out better ways that they can use compostable or recyclable or reusable containers moving forward when there's more population on campus and our cafeterias begin to be more utilized. So hopefully that answers the question that somebody was asking about how we're handling just general solid waste on campus based on COVID. And with that, I think that's gave a pretty good overview. And if you have any questions, I'm happy to answer those.
Thank you, Michael. That was very insightful and definitely some information I didn't know before. But with that, we will now have 2 speakers who will discuss how supply chain has been affected during COVID-19. So with that, I will turn it over to Jackie Blessington and Mrna Myers. Remember, you can go ahead and throw your questions in the Q&A box below. Jackie, I think you're muted.
There we go. You'd think, again, after a year, I would figure this out, right? So Mrna and I are with procurement. And at ASU Procurement, we are part of the supply chain. So if you think about supply chain, you've heard that term probably more during the pandemic than you did any other time in your life, unless of course you're a supply chain management major here at ASU. But procurement plays a role in that supply chain. And if you think of just the simple things that happened and continue to happen, and we see these Amazon drivers at outside our doors on a regular basis, whether they're for us or our neighbors, they're out there. Groceries are being delivered directly to you or to your car while you sit in it. All of that is part of the supply chain. It's a matter of taking raw materials and combining them, transforming them, putting components together to create products and goods that we all want to buy. And at ASU, in our procurement department, we have about 40 people consisting of buyers and systems people and other support to make sure that we have everything that we need at the university on a regular basis. So we support all of the academic and all of the research operations and just the day-to-day operations of the university. So add to that scale and scope of testing and vaccinations that we've heard about so far, and that adds a lot to procurement at ASU. That adds a lot of impact to that supply chain, and certainly a reliance on our suppliers and those manufacturers that come before them. So I'm going to turn it over to Mrna. She's going to talk to you a little bit about some of the challenges and the successes we've had.
Thanks, Jackie. The challenges have started off really early. I'm sure many people, whether you're homesick or it's late at night and you're flipping through channels and you see the home shopping network and you're looking at the bottom ticker tape and there's something like, I don't know, Jackie Blessington just spots 6 thermometers. Well, when we started off early, like within days of ASU has the first positive test case in the state. Nothing like being first at everything. So what we ended up doing was quickly trying to put together a packet so that one, we could protect faculty, staff, students on campus. Part of that included the infrared thermometers. Well, we could find them because we're a scientific university. You know, research is really great to be part of when everything you need to buy is in the scientific world. Instruments, personal protective equipment, all of the supplies necessary to do the testing in the lab or through the drive-thrus or the vaccination sites, all of that. We were steps ahead of many universities, states, cities. We're competing with public, private entities, federal government entities. The supply chain was flipped upside down. We're used to supplies being there. We're used to ordering them. They're coming off the shelf. And then while the public saw a rush for toilet paper, the rest of us saw a rush for surgical masks, N95s, very specific kinds of N95s that we still aren't able to get. But tips necessary to conduct the testing in the labs. We saw those shortages on a worldwide scale that we ended up really having to compete for. And as a government entity, our way of processing orders is through requisition to purchase order. Private entities place a credit card. And so they were able to pull out of the marketplace much quicker than what we were through our normal systems. So we had to do a really quick reverse and start ordering using a purchasing card as well. We had to learn how to forecast everything 3 months in advance. And when the market is volatile on everything you're buying, it gets really tricky. We had to take supply people and embed them with biodesign. Everybody that's on the panel, all of us are on a variety of committees together. ASU got active and supply chain got active right along with it. Unfortunately, many of our products come from overseas instead of within the US made. So a lot of counterfeit products were brought to market. Some of it was completely unintentional. We had people that had access to China as far as supply chain. They had contacts in warehouses. Those people were pretty much in promotional type arenas, hospitality type procurement, getting your pens and your shirts and your hats and your notepads, everything for that type of promotional activity. And that was shut down, right? In the United States, travel stopped, people quit going on vacation. We know we're all on Zoom. We're not in the same room anymore. Conferences were held virtually. So those folks that no longer had the hospitality world got into the personal protective equipment world, and they were bringing in hand sanitizer and disinfectant wipes, and they didn't know what they were dealing with. So that's one of the ways that a lot of counterfeit stuff ended up in the market. Then, of course, the people that thought that they would sell 3M masks that weren't actual 3M masks certified, just to, their get rich quick scheme. So the purchasers had to become really knowledgeable and reach out to EH&S. So rest assured, everything that we bought, EH&S tested before we did a bulk buy. The advantages for ASU is that we have a lot of people that have been in public procurement for decades. Sorry, Jackie, that actually identified both of us, didn't it? Well, and because of that, we had experienced little pieces of this at times. It could have been, I worked on military installations, so I dealt with Desert Storm, Desert Freedom. So to gear up quickly, like Tamara was talking about earlier, we had experienced it before. So we really relied on people within the department and outside of the department to take care of all of the needs. Our contracts and our contacts that we already had established as a research university, we really relied on those. And we still do. Nitrile gloves, we have a source that is, we meet weekly. We're not looking at a shortage of any kind, and we've been lucky throughout this whole process. So our outcomes is that we were able to sustain academic operations. We enhanced research, including the testing and vaccines. Inventory is on hand, and I'm sure everybody has received a community of care kit, and that was put together before somebody else had a great idea and decided to start making kits and sell those. So that kind of wraps up everything that the supply chain has been involved in. And I know that there's reports. NPR had a great discussion about the difficulty getting chips for cars and things of that nature. We have to overcome this pandemic. So all of the supplies have been centered around testing, protecting, vaccinating. We'll get those chips for the cars again soon, I'm sure. Did I leave anything out, Jackie?
No, did a great job. Thanks.
Absolutely. Thank you.
That was amazing. Thank you both. I will again remind everybody, if you have any questions, to throw it in the Q&A box. And hold on, sorry. So now we will have our final speaker, who is able to discuss how ASU has been able to navigate and learn through this pandemic. We have Jim Dwyer.
Hey, thanks, Renee. I appreciate that very much. And thanks to the rest of the speakers. I know I certainly have learned a few things, which is always a huge benefit of being at ASU. So my name is Jim Dwyer. I'm the Executive Director of Auxiliary Business Services, and I work with a lot of our on-campus operations to support students here in Arizona and also at our regional centers and really globally. And we do that through a lot of our existing partnerships. So I think taking it back full circle to where Tamara started and talked about a lot of the partnerships that were started in our response to the pandemic, and a lot of the activities that were developed and will continue to evolve. We really had to shift how we were working with our current partners. And from an operational perspective, it really created some both challenges and some opportunities. So thinking first about opportunities, and I'm sure many of the others on this Zoom would also agree that we found areas where we could really consolidate and integrate our partner messaging to ensure that our students, faculty, staff, and community really had a clear and concise response from ASU on what was happening and what we were doing on campus. I think if you go back to pre-pandemic, there was a lot of, and it's still going to be a challenge at an institution as large as ASU, but fragmented communication. You have different silos, you have different organizations, sometimes all communicating simultaneously with students, for instance. So, we're communicating with you students from an operations perspective, from an academic perspective, from a health and wellness perspective, from a student engagement perspective, and it's a lot. One thing that I think ASU did really well was standing up a cross-functional team that, again, many of the folks on this call were a part of, to really work consistently to communicate a clear message. And that also extended to a lot of our partnerships. So ASU outsources some of its operations, and some operations that even appear, to be operated through ASU that we work with, professionals in the industry. An example of that would be our inter-campus shuttle program. So we have shuttles that travel between each of the campuses, and we work with a partner, Aero Stage Lines, that provides drivers, they provide the maintenance, they really take care of the vehicles and do a fantastic job. They really stepped up in this scenario and worked with us to very clearly articulate and communicate what safety protocols were taking place, what were you doing to mitigate student concerns around availability and access. And some of those things historically would have been a real challenge to do because we would have been doing it from just the transportation lens. And through the pandemic, we really came together as, I think, a university and really put out a clear message around, FAQs and what we're doing and how you can get answers, and really trying to make sure the community was informed. One of the challenges I think that we had, and an area that will continue to be explored from a partnership perspective, is really how we manage the value recognition of a partnership and where we place the risk within partners. Some partners, going back to the shuttle bus concept, we're paying for a service that's being delivered, and our costs don't necessarily get mitigated if we're continuing to offer that service at the levels that we think we need to, which is the full scale. And when we shifted into the pandemic and we saw, reasonably students weren't traveling, they weren't traveling between campuses, we were on lockdown, we still needed to maintain that partnership, and we had contracts. So kind of coming back around full circle to what Mrna and Jackie were talking about, from the procurement perspective, we had contracts that we needed to maintain, we had obligations that we needed to make. So we really needed to make sure that we navigated that very carefully, and the partnerships became really important from a collaborative perspective, that it was more than just a transaction with these vendors. It wasn't just a matter of, were they going to make enough money to survive? Were we going to lose money? Was this a sustainable model? But how could we really work together to make sure that we could meet the service level requirements and that we could sustain the operation to be successful going forward? Another area that I think from a business partner perspective that presented some huge challenges was actually something that Michael talked about in our food service operator, is just the volumes on campus. We have a lot of contracts that are contingent upon guarantees and certain service level expectations based on ASU size and scope, which, for the first time ever and completely unknown to anybody would be strained. So working with those partners to really navigate what volume impacts those we're going to have, how we could navigate those again in a way that we could ensure that we had a sustainable model so that services could continue to be delivered, but in a way that didn't break the partnership. So the word partnership is really the critical piece I would take away from that. The only other thing that I would mention, and really hopefully relevant to all of you, is some of the things that we've adopted from a partnership and operational perspective that I think we'll maintain and will continue to accelerate. So transition to digital service delivery. You heard a little bit about supply chain. I think, delivering services digitally, whether that be through electronic course materials, switching from traditional kind of paper books, looking at delivery models. So not necessarily going to the restaurant, but getting delivery. We've all, I think, really fully embraced the delivery culture this past year. How do we bring those services to campus? How do we bring things like the autonomous robots that we've had out delivering food to a scale that does even more for us? So leveraging technology and really enhancing the way that we deliver services. Contactless transactions. So we really made a lot of effort at the beginning of the pandemic and at the beginning of the fall semester to really upgrade a lot of the systems on campus. How could we make things safer? How could we make things more convenient for people, like contactless transactions, like transacting online, doing things that I think a normal consumer would expect from a regular business that you do business with, but thinking of it is also the way that you may do business with the university and some of the transactions that you need to do. So I think those things will stay and will continue to accelerate. And I think we'll continue to look at how we manage convenience as a part of the experience. I think prior to the pandemic, from a business partner kind of operational perspective, we would look at experience being separate from convenience. And we kind of picked one lane. You were either super convenient and that's why people chose you, or you created a great experience and that's why people chose you. Well, I think what we're seeing is that the great experience can be convenience and ease of use. And we're really looking at our operations and at our businesses in a new light to create really the most convenient, seamless experience possible for you. And some of those practices have actually come out of really just trying to look out for safety, make people feel comfortable, have confidence in the university, want to be here, want to come to campus, want to be a part of what's going on. So some great things I think that will continue to accelerate. And as always, look forward to student feedback, and anyone on the Zoom today that has questions or hears things on campus, happy to engage with and look forward to the collaboration going forward. And that's it for me. And if there are any questions, happy to answer them.
Thank you so much. I, for one, as a student, am very excited to come back to campus. It feels very safe, very comfortable. ASU has done a wonderful job in making sure that students are in the know. So that's great. We do have a few questions and we can go ahead and move into a Q&A session. So for any of you who have those questions, I encourage you to type them now. The first question we have is, what are you prepping for fall semester with the expectation that more people will be in person?
So Jim, maybe you can handle that question from your perspective, how you're anticipating students returning to campus in the fall.
Yeah, that's a great question. We are in full fall preparation mode right now. So we're working with our business partners and our operational units are looking at how we're going to be prepared. And in some examples, that means ramping backup services that we've had to either augment this year or make variations to, just based on the demand and traffic patterns. But at this point, I think the expectation is that we want to make sure that we're meeting service level delivery expectations. So that means you're not standing in lines, you're getting to where you need to go quickly, you're getting the materials you need before the start of the semester. We need to prepare for as much, if not more, volume than we've ever had to make sure that that students have what they need to be successful.
All right, thank you. We have one more question, and it is, with the emphasis on global production in modern manufacturing, what kind of effect has COVID had on supply chain for materials? And I believe Mrna and Jackie, if you want to answer that.
Lauren, I'm going to leave that one to you.
Thanks. That is a great question. And it has been really tough for a lot of entities to be able to obtain supplies because of the worldwide demand. If we were your regular higher ed, not involved in testing, not involved in vaccinations, not involved in research, we would be one of the last to be able to obtain supplies. It has been really hard for others, which is why we have been so active in assisting in setting up community type functions so that testing and vaccines can occur.
All right, perfect. I believe we do have another question to answer, and that is, what will we continue to do after COVID that we weren't doing before?
Well, I'll take a stab at it from our perspective. I think the team that has been responding to the various challenges that we've experienced, I think we'll continue to believe that you can do almost anything given 48 hours notice. So I think they have come away with a confidence that really, we knew anything was possible before. Now we have proven that anything is possible. So I think the teams are just, again, very excited to take this newfound ability to pretty much do anything we need them to do in 48 hours notice and apply it to the core mission of the institution and supporting our faculty and students. And so that's the one thing that I think we'll keep doing.
For the supply chain, we have done a somewhat of a reorganization where we recognized how much of our inventory for goods, whether facility goods or scientific goods, IT hardware was also something that was handled through material management, that those two are really close. All of the devil drop-off kits and the pickup of that happens by material management. So we did somewhat of a reorganization, and we moved our goods team, the purchasers, and some of the inventory group, and made them a unit that is kind of a great bridge between material management and the procurement.
I think from my perspective, the flexibility, I guess this goes a little bit to Tamara's point, but with the flexibility that we've adapted to, I think we will maintain. And I know for me, from a service delivery standpoint, historically, we can kind of count on you deliver a service either per semester or per academic year, and that was kind of acceptable. That was, you got this service and that was your choice. Those days are really gone, and we need to be much more flexible. So depending on students coming in for a month or 2 months, or needing to be on campus for a week or a day, we need to be able to provide services that can kind of scale up or scale back depending on their individual needs. So a lot more customization and flexibility.
This is Michael. I can give some perspective on us. We actually became more efficient. And I'll tell you one thing that's not going to change are these Zoom meetings. I think they're going to stay for a while. But we became more efficient on our routes. We were challenged on how we can fit more waste into certain biological waste bins. We actually use more technology than we did before. So I think that's a huge advantage now that we didn't maybe take full advantage of before, was the use of meetings like this, use of our phones, and ways to track how we go about handling the waste and generating it. And we actually built a better relationship with our vendor, Waste Management, as well, because we were generating so much waste now that they had to make 2 trips a week, where previously it was 1 trip a week to campus to pick up the amount of waste that we generated. So I think, use the technology, we're efficient with our routes, and then building stronger partnerships with our suppliers.
And then Michael, there was another question that came into the Q&A, if you wouldn't mind answering as well.
Yes, I saw that. So unfortunately, we don't handle the solid waste portion at ASU. That is handled by, it'd be a combination of, I think, zero waste and maybe facilities management contracts. So I can't, unfortunately, I don't have a number nationally if solid waste increase or decrease across the nation when due to COVID. If anything, I would say it decreased because you just think of the number of locations that were not in business. People were not visiting, they weren't leaving their homes. They're probably at home and reusing materials in their home then versus going out, except for the amount of Amazon orders that have probably increased across the nation. There's waste generated there. That would be something, I don't know, from a procurement perspective or sourcing, would you say that there's probably more waste being generated because of the amount of Amazon orders? Any perspective on that?
I don't know about the Amazon orders, but I think just from looking on campus, I have my own students, my own kids on campus, and the difference in eating and the carry out and the trash that is comes from all that is kind of alarming, although they are all reusable. And I know that Aramark is doing a great job. I think that has been something that I've just visually seen.
Yeah, I can't answer that on national. I don't have that number, unfortunately.
I saw that there's a question in the Q&A about Starship and our robot deliveries and the concern or the question around navigating when we're back up to full capacity on campus. And that is actually something that we're talking to them about. They've collected a lot of great data this past year on routes and kind of optimizing how they can move around. But we are cognizant that there will be additional factors to consider when we have higher volumes on campus. So we are actually having conversations with them now about flexibility around operating hours and understanding when things are starting, services maybe starting later the first week of class, or skipping the high volume lunch period, just to understand what impact could be on those. So yes, very much considering that.
Amazing. Well, thank you so much, everyone. I want to give a special thank you to all of our panelists. I know you are all extremely busy, and I am very, very thankful that you all took the time to talk to students and families about ASU and business impact and environmental impact. I know I, as a student, appreciated it a ton, and I learned a lot from just listening to all of you. So I thank you all for that. We are going to screen share our flyer for our COVID-19 speaker series. And for our attendees, I encourage you all to come next week, as next week is our vaccination information session. I'm sure plenty of people have lots of questions about vaccines, there's 3 different types: emergency use authorized in the United States. And I just encourage you all to come learn more about the vaccine, learn why it's important we should all get the vaccine. And I just wanted to say thank you again, and you should all have a wonderful day and stay safe and healthy. And I appreciate all of you so, so much. All right. Hello, everyone. We want to welcome you to our 3rd week of our COVID-19 speaker series. My name is Erin Krasnow, and I am an undergraduate student here at Arizona State University studying biomedical sciences. And I am incredibly excited about this week's topic, which is vaccination information. I want to quickly announce that every ASU student is now eligible to get the J&J single-dose vaccine. There's lots of vaccine slots available, so make sure to go and check that out and get vaccinated. Before we begin, I do want to address that I know vaccines and any information regarding vaccines can get very political very quickly. So I do ask that you take your political views aside and just open up your opinions and listen to these facts and statistics and these wonderful, wonderful experts that took the time out of their busy schedules to be here with us today. And just remember that the CDC recommendations and vaccination is the best way to protect yourselves and your loved ones from COVID-19. This webinar will be a little different than our last webinars. Today will be more of a Q&A session. So we have a few already from pre-submitted questions, but we do ask that you write any that come up in the Q&A box below. And now, without further ado, I would like to introduce some of our speakers. We have Dr. Nick Staub, we have Tim Lant, and Anna Moldon. And now, without further ado, we can get into any questions or any topics that our speakers are going to talk about.
We had gone mostly for Q&A format since you'd given us some questions ahead of time. So ask away unless Nick has a presentation. Yeah.
I'm sorry, I do not have a presentation prepared. I do have, we have the questions that we were sent ahead of time, so I'm happy to just start making our way through those.
Go for it.
Okay. So the first question we were given is, what are the biggest differences between the current vaccines available in the US, and is one better than the other? So to start off, currently there are two different categories of vaccines. There are the mRNA vaccines, or the Pfizer and Mrna vaccines. And then there is a viral vector vaccine, and that's the Janssen vaccine. And so both of these vaccines operate on both types of vaccines operate on common principles, and that's essentially trying to get a genetic sequence from the virus into our own cells, and then use our own cells machinery to generate a protein that looks like the protein that sits on the outside of the virus. And so the two different kinds of technology essentially use different vehicles to get that genetic sequence into our cells. So in that sense, these three vaccines are very similar. I would say the biggest difference between the vaccines are that the mRNA vaccines use kind of essentially a fat globule to wrap up that genetic sequence and get it into our cells, whereas the viral vector vaccine, the Janssen vaccine, uses an actual virus, a non-infectious virus as the carrying as the vehicle to get that genetic sequence to the cell. So those are kind of the big differences, and we can talk more, and I'll let some other people talk about kind of how we look at effectiveness of these vaccines at preventing COVID-19 infections. But really, from our perspective in county public health, from Maricopa County and in public health in general, is that the best vaccine to get is the vaccine you can get an appointment to be administered a vaccine. And you really shouldn't think too much about the different kinds of vaccine, because they're all very effective, and we're very lucky to have each of these three and more coming down the pike.
Thank you. Next, we're going to go down and I'm going to go ahead and ask some of these pre-submitted questions. We do have questions coming into the Q&A chat. So whoever wants to answer those, just go ahead and hit that answer live question, then we can get to those as well. We do have another speaker with us. We have Megan here. She hopped on just a couple minutes late. So I'm going to go ahead and introduce her as well. Megan, we are doing kind of a Q&A style webinar today rather than more of a presentation. So the next question we have is, after getting the vaccine, what are some of the symptoms? Is it a bad indicator that people are having some strong reactions to the vaccine?
So I'm happy to answer this one too, Renee, but anyone else jump in at any point. So the common side effects that you have after vaccine can be fever, muscle ache, injection site soreness. So, some pain right there where you got the injection. There can be some headache, and some of these symptoms can be confusing because they could also be symptoms of COVID-19. But the side effects from vaccination usually occur within 72 hours or 3 days of receiving the vaccine, and they really shouldn't last from onset to end more than 48 hours. So any side effects that you have beyond 72 hours after you're vaccinated, you really should consider that that's due to something else, and it could be COVID-19. And so you could consider getting tested if that you have a concern for that. And then, beyond that, I think these are very effective vaccines. So we know that the mRNA vaccines are upwards of greater than 90% effective. And when you have a more effective vaccine, you can equate that to having a more effective immune response. And we want you to have some reaction to a vaccination, or else we would assume that that vaccine is less effective. So the fact that we're seeing stronger side effects with these vaccines, I think really speaks to the strength of the vaccines, and really should be something that you're not trying to avoid as much as just be prepared for should you have side effects.
I wish I had something to add to that, but yeah, I mean, you want your immune system to react. So even if the minor side effects of your immune system reacting aren't the most fun, it's a sign that the vaccine is working, right?
And I can also add that just a month or two ago, CDC published a safety profile for the vaccines from, millions and millions and millions of doses of vaccine given all across the country. And there was nothing in there that would, give us any concern or pause about the safety of these vaccines. They're working brilliantly. And you can find that report if you search CDC to MMWR. If I find it in a second, I can also drop it in the chat. But
and if I could also do one more plug for the V-Safe program. So V-Safe is the CDC program that you can enroll in after being vaccinated and report any side effects that you have. So the data that Megan is talking about, a lot of that data came from the V-Safe program. And it's a great way to participate in this kind of historic vaccine rollout. And it's relatively easy. So if you, we should make sure that all those ASU students who are being vaccinated are getting that information to enroll in V-Safe.
And if in anything, you would kind of expect that data to be biased towards like more severe adverse events, right? Because if something did happen, you're more likely to report it and to be safe than you would be if you were, had no reaction whatsoever. So.
All right, thank you all. We have our next question is, how long should we wait to go out in public after receiving the vaccine? How much can our behaviors change once we are vaccinated?
Well, so I would say you don't need to wait to go out in public at all right now. You can go out in public and you can do it safely by wearing a mask that fits correctly, avoiding large crowds, and being aware of individuals who you are with who are either symptomatic or could be close contacts of cases. So, with the appropriate mitigation efforts, going out in public is safe. Now, if you're vaccinated, going out in public is one step safer. And then again, with Janssen vaccine, Johnson & Johnson, one shot and you're done. So then you would be considered fully vaccinated about 10 days after that vaccine. But even for the Mrna and the Pfizer vaccines, there is some protection after that first dose, and then the full protective effect of that vaccine series comes after that second dose, and again, a 10-day period after being vaccinated. So So I would say, you know, really until you're fully vaccinated, you don't start to reap some of those rewards of being fully vaccinated, such as, you know, CDC guidance that you can then travel, you can meet with other people in a household who have either been vaccinated or are not yet fully vaccinated. So that's when, you know, your full vaccination status really buys you some additional leniency in terms of guidance. However, I don't want people to be afraid of going out in public now. You can do it safely, and vaccine is just an additional mitigation effort that we can add to keep you and others safer.
All right. Now our next question, we're going to keep going on here, is how long will vaccine immunity last? Will it be a yearly shot? Do we have any insights into long-term protection, or can we only speculate?
Megan, I think you're probably most up to date on the research on this one.
I mean, there's still, I think, a healthy amount of speculation here. So, right, you can get immunity from natural infection, or you can get immunity from vaccination. And the data that we have so far on natural infections shows that you probably have antibodies for at least 6 months. People probably think it's longer than that, but we just, you know, we don't know. The data's not there yet to know how long that immunity lasts. For vaccine-mediated immunity, it's probably longer. But again, these vaccines are brand new, so we don't know. And you know, there will be ongoing studies looking at kind of immune response and antibodies over the duration following vaccine, and we'll be able to tell, I think, you know, whether they're waning or whether they're persistent. But you know, my feeling is that most people think that there'll probably be some sort of booster vaccine that we have to get, but we're not sure quite how often yet.
And
also, it's going to be slightly different for everyone. With most vaccines that we have presently, you know, some of these vaccines are good for years and years, but, you know, even looking at different people, someone, you know, it sort of wanes over time. It's not like a light switch where the vaccine gives you full protection and then all of a sudden it turns off and you have to go get it. Just sort of vaccine efficacy just sort of degrades a little bit over time, and then eventually, if it's not quite enough to protect you, then that's when it's time to go get another shot for all vaccines. So it'll be similar with this one. So it's slightly different for every person, but it could potentially be years. We just have to wait and see.
And when we have an answer, I guarantee you it will be in the newspaper headlines. And we know that will be news.
That is true.
All right. Our next question is, what is the difference between the vaccinations and gene therapy? What are the short and long-term effects?
Anna, that's you.
So that's me. Okay. So the vaccine does not permanently change your DNA in any way. It tells your body what to make, right? The mRNA is basically just like a little instruction manual for your immune system that says, hey, make these things. But it's not the kinds of gene therapy that actually alter you permanently, right? It's just helping your immune system get the hang of making something. Whereas gene therapy actually usually changes your genetic code, and this absolutely does not do that. Nick, do you want to add anything to that answer? There may be a set doctor answer that.
No, I mean, I think that's absolutely true. These vaccines are not gene therapy. The mRNA the recipe that Anna just mentioned degrades after just a couple of weeks. And that's kind of the extent of how long your body makes those antibodies to COVID. So it's really important to know that this is distinctly different from gene therapy.
Phil is asking what examples of gene therapy would be. I'm trying to think of any that are actually FDA approved yet. There are some that have been trialed, but I don't know if there are any approved gene therapies yet.
Right. I mean, I think some of the biggest ones that you can think of are, you know, treatments now for cystic fibrosis and sickle cell anemia. Those would be kind of considered gene therapies. But again, those are relatively new technologies. And again, as Anna said, not widely in use in clinical practice as of yet.
Gene therapy is a wonderful goal for a lot of diseases, but we're not really there for most things. It's more of a theoretical concern yet than a realistic one.
All right. Our next question is how are hold on. How are efficient, like gosh, I can't talk right now. I'm gonna move on to the next one. I'm gonna figure out how to talk again really quick. The next question is, were randomized controlled trials used?
So my simple answer, and anyone else who does more with trials and research can hop on, but yes, they were placebo controlled. So individuals who are enrolled in these trials either received vaccine or not vaccine, and then over time were followed to see how many cases of COVID occurred in each of those groups. So that is the definition of a case control or placebo controlled trial. So it's kind of the highest standard in terms of clinical trials. And when I'm talking to groups and kind of explaining what happened during Operation Warp Speed and how were these vaccines able to be developed in record-breaking time, it's really important to know that no step of that process was skipped over. Everything was just sped up. And so, you know, the quality of these clinical trials, and that's what's reviewed by the FDA when they apply for the EUA or the emergency use authorization. There's a lot of scrutiny of those trials and how they were conducted, and all of these trials for these vaccines have been, you know, have met the highest standards of the FDA.
And I may also add to that when it's in a clinical trial setting, it's called efficacy. That's the word we use because it's sort of under controlled situation. How does this vaccine work, right? And then when we roll it out to the real world, it's called effectiveness. How does it work, you know, in the real world when we give it to real people, not under trial conditions? And, you know, the exciting thing about this is the effectiveness data from sort of Israel, from places in the US. A lot of data came from here in Arizona, from first responders. That real world effectiveness data is holding up to the same levels as the trials. So that's, you know, kind of an additional layer of evidence that, you know, it works as well as we think it works from the results of the trial.
That works perfectly because we have another question about how are efficacy rates determined?
Yeah, it's exactly what Dr. Staub was just talking about. We use a clinical trial, placebo-controlled clinical trial. It was a predefined outcome of what proportion of people in both arms of the trial, so the vaccine arm and the placebo arm, had severe disease, and then we look at the difference between those two groups, and that's essentially the vaccine efficacy.
And if I can just say one other thing, we were talking about the differences between these vaccines, and you know, there's been a lot of attention paid to that number, that efficacy number. You know, anywhere from 70 to 90%. What were our goals, and did they eventually become? And it's important to note that each of these vaccines and each of their trials defined their endpoints and what they determined for efficacy slightly differently. So it's really difficult, and we have tried to compare them, but it just is, it's difficult to do. So that's why when we get to comparing efficacy, a lot of us will just kind of try to steer the conversation in a different direction because it's comparing apples and oranges. And what we really like to focus on, and what all of these vaccines do, is prevent hospitalization and death. So whereas we can't quite define mild or moderate disease because they're all a little different, we do know what being hospitalized means, and we do know what dying means, and that's the same across those 3 vaccines, and they're all very effective at doing that. So that's really where we're trying to push the message that these vaccines are all quite similar and equally effective.
And that nicely answered one of the questions that's appeared in the Q&A section. So perfect timing.
Okay, we are gonna move right along. We have a couple more just about vaccines that we've had, and then we can go ahead and answer some in chat, and then we can move on to some of the more pre-submitted ones. So the next question is, if I've already had COVID-19 and recovered, do I still need to get vaccinated? How effective would the vaccine be in this case? And is there a time period someone should wait before getting vaccinated after recovering?
So I got to jump in here because my boss, Dr. Rebecca Sonnenschein, sits on my shoulder whenever this question is asked. And we believe strongly in Maricopa County that even if you've had a previous infection, that you should be vaccinated at your first opportunity, as long as you are no longer in isolation. So once you've completed your isolation from your active infection, you should consider yourself eligible for vaccination. And this was touched on, I believe, earlier, but one of the questions out there is how effective is natural immunity? How effective is natural acquired immunity versus vaccine acquired immunity? We have a lot more data on vaccine acquired immunity because those individuals were run through clinical trials. We don't have the same data on individuals who were naturally infected. So we know, so because of that, we encourage anyone who's had natural infection to be vaccinated anyway, because we feel like that's the safest way to assure that they are protected against future infections.
And there's a bit of good news here too for folks that have been infected. Once you get your first dose, if you're getting the Mrna or the Pfizer vaccine, it's shown to work quicker. So you can get the vaccine acquired immunity. It really starts to kick in after the first dose instead of the second dose. So that's really good news.
You should still get your second dose.
Yes. And that reminds me, Tim, to individuals who've had a previous infection often will have stronger side effects after that first dose of either the mRNA vaccine, so that's Moderna or Pfizer. In individuals who've not had a previous infection, their stronger side effects are usually after that second dose. And that makes perfect sense immunologically, but it's just a good thing for individuals to know if they've had a previous infection.
All right, perfect. Our next question is, after getting vaccinated, will I test positive for COVID-19?
So that depends on what, sorry, Anna.
No, go ahead.
It depends on the test you're talking about, right? So if you are talking about a PCR test, so that's kind of the gold standard and what we use to define a definite case, you would not test positive for a PCR because you were vaccinated. There are antibody tests or serology tests, and those are tests that specifically look for antibodies to COVID-19 or look for your immune response to a previous infection. Because these vaccines tell your cells to make the protein essentially that is tested for on those serology tests, there are certain serology tests that you would test positive for after having the vaccine. Not all of the antibody or serology tests look for that particular protein. So some serology tests you would test positive for, and others you would test negative for. But both the PCR tests and the antigen tests, and an antigen test is what often is referred to as kind of a rapid test. Those tests would be negative unless you actually had a COVID infection. And anyone, please feel free to add or correct that.
Yeah, so at ASU, the free tests that we give to all of the students that are the saliva tests where you spit in the tube, those are all the PCR tests. So that's the one that's going to test negative, right? And then for the one that could test positive for the serology, that's usually a finger stick. So you got to put a little blood down for that one. So that's how you can tell them apart here.
All right, so I'm going to move into just a couple that were put into chat just now. We've had a couple questions about quarantine after vaccination. I'm going to address one of them that says, so the CDC is now saying that someone who has been vaccinated within the past 3 months does not have to quarantine after coming into contact with a COVID positive person. How and why does this work? As well as why do people who are vaccinated still need to wear masks?
All right, I'll take the first stab at this. So that is the CDC guidance, and so that 3-month period. So it's actually not just 3 months anymore. Now there is no end time for quarantine after you're fully vaccinated. So again, for the 2-dose series, that's 10 days after your second dose. For the single Johnson & Johnson vaccine, 10 days after your only dose. And that starts a period after which, if you come into contact with a known COVID case and you're a close contact, you do not need to quarantine. And that is because we are more certain of the effectiveness of vaccination than we are after a natural infection. So again, that is, you do not need to quarantine as long as you are asymptomatic. If you are in close contact with a known COVID case, and in the 14 days following that close contact, you develop symptoms of COVID-19, you should isolate and consider testing. And the reason why that is because we've been talking all about effectiveness of vaccine, and no one has brought up 100% effective. So we know that even if you've been vaccinated, there's no 100% assurance that you won't contract COVID-19. So that is why, again, why you need to still watch out for symptoms in that 14 days after a close contact, but you do not need to quarantine. And that also is why you still should mask when you're out in public. So another person asked, either in a question or I think in the chat, whether or not you could still carry COVID-19 after being vaccinated. And again, we just don't have all of that data. We're getting more data to suggest that individuals who've been fully vaccinated are less likely to carry the virus. But we just don't know enough to say absolutely that can't happen. So until we know that, you can fully protect yourself and others by wearing a mask even after you've been vaccinated when out in public.
In some ways, the still masking in public is the being socially responsible and making sure you're doing everything to protect yourself and the people around you, even if it may be fine. We don't know that for sure yet, and we will keep getting better and better data, but it's still worth being cautious until we really know, because the more cautious we all are about these things, the faster we get our lives back.
And, you know, active disease is still high in our community. 750 cases reported today. Numbers are ticking up just a little bit, and that's just what we're detecting. So there's also, that's kind of the tip of the iceberg. So there are more cases out there that we're not detecting. So, you know, also while transmission is still so high in the community, wearing that mask is kind of that extra layer of protection for you and for others.
All right, and then kind of moving along with that one, we have a question in the Q&A box that says, do you know if folks who test positive months after being fully vaccinated, might it be one of the variant strains?
It could be. Unfortunately, we have increasing evidence that some of the variants, the vaccines are less effective against. It's still, you know, relatively early evidence, but as Nick said, the vaccines are not 100% effective. And, you know, they are near 100% effective in preventing severe illness and death, which is incredibly important. But, you know, you can still get mild COVID afterwards. And everyone is keeping a very close eye on the variants and how the vaccines are doing against the variants. And you'll see that in the news a lot. It's possible, not guaranteed, but possible. And I'm guessing someone else should add more to that answer too.
Well, it's a plug for getting vaccinated now and as soon as you can, because the generation of variants increases when there is more spread of a virus and more opportunities for it to develop those genetic variations. So the quicker we can get people vaccinated and stop the transmission of the virus or decrease it, we decrease the natural drive to make more variants. So this is really our opportunity that we have to get vaccinated and lower transmission and stop variants so that you know, the vaccines can continue to work against the viruses that are out there. I will tell you specifically to the question that was asked, in the state of Arizona and particularly in Maricopa County, we are tracking cases of individuals who test positive for COVID after they have been vaccinated. And we are trying to obtain those specimens that tested positive, that test that was positive, so that we can test it for variants, so we can get more information on whether that is the case or whether that person, for whatever reason, simply did not have full protection and developed COVID. And then one other thing I will say, because you'll hear about these cases of people getting COVID after they've been vaccinated. So two things to remember: it's not 100% effective, so they can get COVID. The other thing is there's a period of time. The whole reason why we say there's 10 days until you're fully protected from that vaccine, because before you're fully protected, if you were exposed either before your vaccine or in that time period between being vaccinated and when your immune system has had time to respond, you can develop COVID. So we definitely are hearing of those cases. And again, all the more reason to continue every effort to protect yourself even after you've been vaccinated, including masking.
All right, so next we have a question. This is more along the lines of reactions to vaccination and some of the reactions that we're seeing from vaccinating. Somebody specifically asked about their allergies. They grew up getting allergy shots. They have seasonal allergies, allergic to sulfa and glutamate, and they're wondering if they should get the vaccine.
Yes, get the vaccine. Like specific questions about your own medical history really are best directed at your physician or clinician, because I can't speak for everyone, but the only absolute contraindication, so the only absolute reason why you shouldn't receive these vaccines are if you've had a severe or immediate reaction to one of these vaccines or to one of its components. And I think the most likely component that somebody would have been exposed to prior to this vaccine is something called PEG, or polyethylene glycol. It's a common ingredient in a lot of injectable medications. So these individuals would have a history of having some kind of injectable medication that they reacted to. If you have any questions and you've had any kind of allergic reaction before, I highly recommend that you just have a conversation with your physician to make sure that you are comfortable with getting the vaccine. But those other reactions do not prevent you from receiving any of these vaccines.
All right, thank you. I think that that's all we have for the questions regarding the vaccine specifically. If any of our speakers have anything to add about the vaccine specifically, you're welcome to unmute yourselves and interrupt me. But if not, I think we're going to continue along, and then at the end we can address Q&A chat questions. So the next subset of questions is kind of about anxieties around the vaccine. I'm kind of addressing those. So the first question we have is, how do we calm anxieties about the thought of people who don't get vaccinated, especially going back to campus? What is the best plan to avoid that?
Getting vaccinated yourself and talking to your friends and family about your experience with the vaccine can be incredibly helpful. I know that some of my friends were a little bit hesitant about getting the vaccine, and the fact that, my parents have gotten it and I've now gotten my first dose, and could talk to them about the process and the reactions and that I'm fine, made a really big difference in their willingness to get the vaccine. So the good news is, if you're vaccinated, you are well protected from severe illness. So those people around you who don't get vaccinated, it's not great, but you do still have some protection. And, talking to your friends and asking if they're vaccinated before you plan hangouts is completely reasonable. It's reasonable to say, hey, I'm vaccinated, are you? Before you decide to have coffee with someone. And that's okay, but it's also reasonable to think about the people around you and who you want to hang out with if you're really worried, with care for their personal situation, but also, protecting yourself and being a little careful about what you choose to do.
And I will just add that we've known that masking is much more effective than these vaccines for a longer period of time now. So, if in those cases where you are worried about yourself and about others, it's one of the reasons why I am happy to still encourage masking as a very effective way of mitigating transmission of disease. And I'm encouraged by the fact that a lot of private businesses and other organizations have continued to encourage masking.
All right. I also want to take this time to remind all of our attendees that we will not be addressing any return to campus questions. You can direct those later at some Michael Crow forums and all those types of places that you can find on Undergraduate Student Government's Instagram page. They'll be addressing those later. So we have another question kind of around anxieties, reactions, side effects, those types of things. Another question is there any real risk for a child developing a mental disability from a vaccine?
No, we have about 30 years of evidence at this point that vaccines do not cause autism. That is, these vaccines are incredibly safe. Vaccines in general are incredibly safe and very carefully studied before they're allowed onto the market. that is not something that I would consider a concern with these vaccines or any vaccines that we currently have.
And I would just like to add that they're studied not only before they hit the market, but a lot of analysis goes into following vaccines after they're out. And yeah, this is just not a concern. There are other side effects. There can be severe adverse effects once you start talking about a vaccine being administered to millions and millions of people. There will be some severe adverse effects or side effects, and we'll track those. And CDC is specifically for the COVID vaccines, investigating all reports of deaths after vaccine or other severe side effects. And so just be reassured that that data is being collected and continues to be evaluated as these vaccines and all vaccines are administered.
All right, thank you. We have more questions on the same subject. I'm going to ask them from the chat box and the Q&A box this time. We have our first question says, some people are scared of long-term side effects of the vaccine. Can you speak to the risk of this? I know we kind of addressed this a little bit earlier as well.
So I would just say, so again, long-term side effects of these vaccines are unknown, right? Because we haven't had these vaccines long-term. So we will continue to get that information. And just so that everyone here understands, that is why these vaccines are currently being released under emergency use authorization, as we have more time to follow up on individuals for a longer period of time. That is the data that is needed by the Food and Drug Administration to give a full authorization to these vaccines. So we will continue to gather that data. It'll be reported to the FDA, and eventually it'll be fully authorized. But again, we don't know, we can't say with any absolute knowledge what the long-term effectiveness of these vaccines and what the side effects will be. However, we know from other vaccines that the side effects, we're not expecting many long-term side effects. And you always have to, when you're thinking about whether or not to be vaccinated, you have to think of the long-term side effects of the potential long-term side effects of that vaccine and the known long-term side effects of the disease. And already in this short period of time, we are seeing cases of individuals with COVID-19 who've had very significant long-lasting effects from that infection. And these are commonly referred to as long haulers. We are learning more and more about these individuals every day. But really important to think that, you know, if your problem with being vaccinated is the long-term side effects, you have to compare that to what we know about long-term side effects from disease and let that be a key component of your decision.
And if I can, so I'm one of the co-investigators on the long COVID study here in Arizona, the big COVID cohort study. And the number of people who are experiencing persistent side effects is huge. And you know, I'm not trying to be a fearmonger here at all. From the literature, we're showing that we're seeing ranges of anywhere from 25 to 40% of people with persistent symptoms 3 months after their diagnosis, and sort of multi-organ systems. We're seeing, interestingly, people think that it's just the folks in the hospital with really severe COVID who are getting this long COVID, and that's not the case. We're seeing it in really mild cases. We're seeing it in even asymptomatic cases from the community who are never hospitalized. Young people, old people, men, women, we're seeing it in everyone. And there are a lot of, you know, mental health diagnoses that I think are following this long COVID diagnosis as well. And so that is a risk you take from acquiring immunity from a natural infection.
All right, so we have a couple questions about herd immunity. So our first question is about herd immunity. There are many people that will not get the vaccine. They want to let quote unquote others get it to provide herd immunity. Will this theory to let other people get it work? To me, this is just as bad as when people refuse to wear masks.
Oh, I know a lot of us are jumping to answer this one. I know Tim said he wanted to start.
I'm ready. I'm ready to go.
And then I'll jump in. I know Nick will. We're all chomping at the bit to answer this one.
Yeah. So I'm the math guy. So we started using this word herd immunity because we actually learned it from people who do agricultural livestock, and they vaccinate herds. So they had a little bit different context. They wanted to keep their herd safe, so they just needed to know how much of the herd to vaccinate. The thing that's really important to understand about herd immunity is that it's not a magic number that once we hit it, COVID goes away. It's just a number that says if we get enough people with natural immunity and vaccine acquired immunity and get everything going in the right direction, that cases will start to come down again. But people can still get sick from COVID, and people who aren't vaccinated are significantly higher at risk to get sick from that. Will people get a benefit if enough people get vaccinated? Yeah. There's two reasons why the vaccine works. One is for people who are directly vaccinated, and the other is from people that would have gotten an infection from someone else who got the vaccine and then they didn't get it. So that transmission chain will get broken. And the only people that are really going to be at high risk still are the people that don't get vaccinated. And yeah, everyone who gets vaccinated will be doing them a bit of a favor. I think if you want to look at this question from the perspective of, is it fair? Well, I mean, no, not really. There's no promise that it's going to be fair, but we're already starting to see some effect of cases going down while we're in the middle of this giant, massive vaccination campaign. And we've already been able to show that there's a reduction in cases, there's a reduction in hospitalizations, there's a reduction in people who are dying, and they're pretty significant numbers. So in short and in summary, yes, people who get vaccinated are necessary in order to reach the magic herd immunity number. And yes, it will limit some secondary transmission. It would be great if everyone would just get vaccinated, because there's also no upper limit to it. I mean, if we can get 90 or 95 or 100% of everyone vaccinated, that's fantastic. And that's really what it takes to make COVID, effectively go away, instead of just bouncing around and percolating and hanging out with us for a while. And the longer that lasts, the more risk there is that we're going to see more of these variant strains and mutations. Then we're just hoping that we don't get one that's weird and makes the vaccine less effective.
And, I'll say from kind of an epidemiology perspective, obviously this magic number that we calculate, this herd immunity threshold, depends on the transmissibility of the disease, which in turn depends on human behavior, right? So in many cases, is it possible that we could be approaching some sort of herd immunity threshold in parts of the country? Maybe, but that's also in sort of a masked, socially distant world. And so it doesn't mean that we've reached herd immunity in a world where everything returns to 2019 pre-pandemic level, because then as we open everything up, that herd immunity threshold is going to shift up again. Also, there's so much uncertainty in those estimates, right? Like, we still don't know how long this natural immunity lasts. And so we have a whole probably 25% of the population of Arizona that's been infected, but only about 50% of them have been infected in the last 6 months or so, which is the period of time where we kind of know that the antibody response is probably there. But beyond that, we really don't know. And as we progress, then this sort of proportion with natural immunity is probably going to be going down. So yeah, I'll stop there.
Yeah, and I'll just say, this is going to become our, hopefully relatively soon, really singular focus in our emergency response in Maricopa County, is how to reach out and educate those people who just need more of their questions answered in order to decide to be vaccinated. Pretty soon we're going to hit those people who were going to get vaccinated, regardless of what the data showed or how effective the vaccine was or how long they were going to have fevers afterwards, they were just going to go and get vaccine. And so now we're kind of reaching out to those who are very willing to be vaccinated, but for a variety of reasons may not be able to access our current vaccine operations. So either these large drive-through vaccine pods or kind of the smaller events, the more targeted events that Maricopa County is hosting now. And then, we really just need to get out there and educate as much as possible. And that's why I will never say no to an event like this, to get out and really share with people what the truth is, because, it really does make every bit of sense in my brain to be vaccinated, for everyone to be vaccinated. It's our best chance at, as Megan and Tim said, getting back to pre-COVID life and that lifestyle. So, herd immunity, whenever we get there, will be fantastic. And I just hope that we get there sooner than later so that we can avoid some of the ongoing issues with variants and infections after vaccination.
And just remember that obviously not everyone can safely take the vaccine, and not everyone has an immune system that will respond to it. And so those of us who can take it should take it to protect the rest of the community around us. And we don't have a vaccine approved for kids yet, right? And that they account for about 25% of our population. So that's 75% of the adults. And so that doesn't give us a lot of wiggle room in terms of kind of reaching this herd immunity threshold. So we really need to encourage everyone who can take this vaccine to take it.
Yeah, thanks, Megan. I just found one more soapbox, and that's schools, right? So just as you mentioned, we don't have vaccine for school-aged kids. And these have been kids who've been out of school for, in some areas over a year. And that's been very detrimental to them. So the fact that we're getting kids back into school and we've gotten a whole bunch of teachers vaccinated, and we're really working hard with schools to make sure that that's a safe space, and we want them to continue operating. So the more people we can get vaccinated so that those teachers feel comfortable in school and those kids can be in school, that is really critical and a good reason to promote vaccination amongst 100 other good reasons.
All right, and kind of following along with that, we did have a question on what people can do to kind of reduce the stigma against, getting the vaccine and everything. Would love to get some of your professional takes on this, if it's just education or, some other things that maybe we can say to our family members to get them to take the vaccine, those sort of things.
I think one of the things that I have learned working on misinformation and on conspiracy is that just telling people that they should because you say so and because the scientists say so doesn't often work very well. These conversations go way better if you try to ask people why they're worried and address the specific reasons why they're worried, rather than more general answers. So that's really hard to do on something like Twitter, but it's a lot easier to do when it's your sibling or your cousin, or in my case, a bunch of my friends. And having those conversations in ways that are trying to encourage the person to think through things and think through whether the reasons they're hesitant to get vaccinated are just anxiety or actual reasons and things that can be answered with the studies we have and the science we have. And then sometimes helping them find those resources for themselves rather than just giving them to them is also quite effective. But I think the key to those conversations is compassion and understanding that their anxiety is real, even if you disagree with the reasons that they are anxious, right?
I was going to agree completely with Anna here. On our case investigation team, we spent a lot of time on empathy training. And being able to communicate with empathy. And so, listening to people, validating their concerns, letting them know that you understand that they are concerned, I think makes a difference. And there are lots of trainings out there that we can provide, or if you're interested, you can talk to any of our case investigators. I saw Nicole on the chat there who asked one of the questions, and some tips on kind of engaging people with empathy in some of these conversations.
And I completely agree, and I'm happy to stop talking as soon as I stop being asked. But I think storytelling is one of the most effective things that we can do now that we have so many people being vaccinated, and now the CDC has given us a couple little carrots that we can start using as reasons to be vaccinated. You can go, meet your loved one who lives in long-term care, and you haven't been able to see for years, and seeing those pictures of grandparents with grandchildren and starting to tell that story about vaccination, I think is going to be very powerful. I will do one plug for TAPI, the Arizona Partnership on Immunizations, has been developing a kind of a crew of educators, or maybe you could even call them storytellers, healthcare professionals, clinicians of all varieties, with a diverse background, both racially and ethnically, who have signed up to be available as requested by different communities in Maricopa County to go and serve this role, to go and talk about vaccines in those communities that they know. So it's not just a scientist standing up and talking about how the vaccines work, but really what are those stories, and they can effectively answer questions that are being asked of them. So that is a service that is growing. And again, you can get more information through the TAPI website, but I think that's going to be really effectively as we look into these communities that continue to be hesitant, not just as a single person, but as whole communities. And if we can get just a couple of leaders in those communities to say, I think this is safe, and then get the vaccine and tell their story, I think this can be, that's the way that we continue to move the needle on herd immunity.
I just want to really quickly second that and say that we have quite a bit of research in public health communication showing that storytelling is one of the most effective communication mechanisms. And so those kind of stories, right? I was talking earlier about I got the vaccine and this was my experience and I'm fine. But also one of the things I've said to my friends is, because I'm getting vaccinated, I can go see my parents that I haven't gotten to see since October. And that is incredibly important to me. And that's why I was so interested in getting vaccinated, right? And that gets through to people a lot more than any scientific knowledge or statistics that I can give them a lot of the time.
All right, thank you all. That was actually very, very helpful. I think a lot of us resonate with, wanting to tell our family members and friends that this is important to do, and this is something that is not only going to benefit themselves, but benefit, the entire community, and, kind of resume life as we know it. And we are kind of nearing the end of our questions. So if any of our attendees have any questions, you can go ahead and post them up in there before, we're all done and said with. So we have our next question. This is kind of an oddball question of, I know some people who are opting to use alternative drugs to prevent contracting COVID-19. Are you aware of these, and would it be better for them to use these than doing nothing?
So it is a little vague. I don't know what they are referring to. There are not any approved preventative medications for COVID-19. So I would hesitate to say that they should use any of these things. Now, there are a lot of kind of over-the-counter remedies and things that people might do just to try and boost their immune system or otherwise be healthy. I think that is in general fine. I encourage everyone to be healthy. It makes them weather any infection better. But in terms of any, I think specifically they said alternative drugs, I would not know of any that I would recommend.
I think there have been a lot of stories circulating online about things that might prevent COVID infection. And second, everything Phil just said. When you see these things, it's always worth checking out reputable medical sites to see if they are real and if they in fact have any effectiveness. But there are a lot of stories circulating about them, and it's worth being cautious and checking with, doctors and medical sites about whether they're safe and just, your usual vitamins or not in some cases.
All right. Megan will be joining us back here shortly, but in the meantime, I am going to ask a couple questions regarding kind of FDA approval and that whole process of the vaccination production. So first question is, what is the difference between FDA approval and emergency use authorization? Why are these vaccines only approved for emergency use authorization and not full-blown FDA approval? I do believe that this was somewhat addressed earlier, but I think it wouldn't hurt to kind of address emergency use authorization.
Yeah.
So just a quick comment on this. I think everyone's hearing the phrase emergency use authorization for the first time. It's not really something that we commonly have talked about before COVID was around. But it's a formal process that's been around that the FDA has been using for years and years. And what they do is they use it for situations where it's hard to test a product because there's a disease that's either new or something that's not around, and it would require some kind of biological accident in order to see it, right? So for example, smallpox, we haven't had smallpox since the 80s, but there still are new drugs for smallpox. When we produce those drugs, they get what's called a pre-emergency use authorization status, meaning that they filled out all of the paperwork, they've designed the study, they know what data to collect, they know how many people they want to enroll in it, and they want to start to prove safety and efficacy. And if something were to happen, which is super unlikely, but if something were to happen, then that emergency use authorization process is the formal process that we go through with the FDA in the United States. Once the data is available to reach the standard for a drug that's in use and make it to full approval, then the drug companies, the pharmaceutical companies, can apply for full authorization, and then it can become either a commercial product or, in this case, something that's sponsored by the government. So we're going in that direction, and the companies will be continuing to do additional data analysis now that they have large enough sample sizes in order to go for full authorization. So emergency use authorization, it shouldn't be alarming. It's a well-established procedure, and they've already checked for both safety and efficacy in order to even say that it has emergency use authorization. It's just a slightly lower standard because we don't have enough time to really follow up people for an extended period of time yet. So, but it's coming.
And I think, Renee, I mentioned earlier when I was talking about the emergency use authorization that that no steps of the regular process by which a new product comes to market were stepped over or passed in order to get to the EUA. And specifically, I think what really, in my mind, helped things just move much faster was the fact that the federal government assured these companies that were in the process of rolling out products that their product would be paid for. and that they should start manufacturing that product ahead of getting the emergency use. It doesn't make any sense for a pharmaceutical company to start manufacturing a product at the scale that these manufacturers did prior to knowing that they were going to be approved for emergency use. And so in general practice, they don't. And so the fact that we had vaccine rolling out days after it was granted emergency use was all because of that financial assurance that the federal government gave. So I think that is the single biggest factor that really explains how this was able to move so much quicker. That, and as Tim just said, in order for something to get emergency use, there has to be an emergency. And certainly there was with COVID, there was a public health emergency declared. And so in that setting, yeah, things do go faster because it's an emergency response, not a standard response.
It's also, I think it's also worth noting, since Renee had asked about the speed of vaccine production, it's worth noting that, you know, SARS-1, which many of us call SARS Classic to stop having to do the numbers, was in 2003. And so particularly the government has been interested in developing technologies for coronavirus vaccines for a long time. So one of the reasons that we could get to a vaccine so quickly is that we had 17 years of scientists working on vaccines for this type of virus. So we were able to adapt those technologies and get to this vaccine incredibly quickly. But, you know, there is a lot of research underpinning this that had been going on, and a lot of attempts at vaccine development that had already been going on. So while it looks to a lot of us like we went from zero to vaccine in a year, in fact, this is the culmination of scientists who have been working incredibly hard on SARS Classic for 17 years to get us to the point where we can do this. And we got, in some ways, incredibly lucky that we had all of that research on the original SARS outbreak to get to this point so fast.
Right, and mRNA vaccines are made to be a platform technology. So the United States government had Moderna make an mRNA Zika vaccine in 2015. So it's not just the science, but it's also their manufacturing plant. So all of the bioreactors and everything else that it takes to make vaccines at scale were already investments that the government had made, 2015.
And I would just say, I hate to talk about the next pandemic, but just be prepared that vaccine response, if it's vaccine eligible, will be even faster than this was, because we have been able to learn so much, certainly on the science and production side, but in public health too, about how we responded to this and how we rolled things out. We've done a lot of mass vaccination exercises over the years, but this was our first real opportunity to test that out, and a lot of lessons learned.
And we do have a conversation about the potential of mRNA vaccines for other outbreaks. mRNA vaccines are intended to be a flexible platform technology, meaning they can be adapted to new diseases. The government has been very worried about pandemics of emerging infectious diseases for a long, long time. I think people hear more about concerns about a flu pandemic, but this is at, I think, the local and the federal level, this emerging pandemics are something that a lot of us worry about. And so flexible platform technologies are crucial to rapid public health response.
No one wants to talk about the Russian vaccines or the Chinese vaccines?
They seem to work.
Well, that is all of our pre-submitted questions as well as some of the Q&A questions. But Tim, if you want to talk about the Russian and the Chinese vaccine, you're more than welcome to.
He was just expecting impossible questions.
I don't speak Russian or Chinese.
I also think we're going to have plenty of our current vaccines to go around. Where certainly, I think from the U.S. perspective, we're not going to need to kind of worry about other international vaccines. But when you start thinking about the vaccine response for the world, which we have to start thinking about, right? Once we get our country vaccinated, we live on a planet Earth, and so we really do need to be thinking ahead about how do we support other countries who don't have the same resources we do, and I think those other vaccines are going to play a role.
Yeah, I added it up once. The United States government has contracts to purchase 1.3 billion doses of vaccine. And the most vaccine that we would need in our country of a little over 300 million people, if all of those people got a 2-dose vaccine, would be, of course, 600 million. So we've got 1.3 billion, we need 600 million. We have purchased more than double the amount of vaccine that we need.
We've purchased and we've manufactured. I mean, we're sitting on a lot of vaccine. So just as AstraZeneca was an example, just a few weeks ago, we did support some other countries in which the AstraZeneca vaccine was already authorized for use.
There's also a question about why Europe is slow on their vaccine rollout. One, Europe has different regulatory agencies than we do and different regulatory requirements. But two, a lot of European countries have been vaccinating for quite a long time. Some of them have used different vaccination strategies than we have. But each country purchased different amounts of vaccine, like pre-purchased. So the way that this worked was people basically said how many doses they wanted for different vaccines. Different countries ordered different amounts of each vaccine. And so that delays in approval or manufacturing have also affected how quickly various countries are getting their own vaccine.
There's a really interesting organization called CEPI, which is the Coalition for, too much government time. I forgot an acronym. Anna, what's CEPI?
I just realized that I don't remember, and I will look it up because I should remember.
P is for pandemics. Anyway, this is a big sort of multinational government private sector partnership. So there's like some governments have put money into this organization. The Bill and Melinda Gates Foundation has, the Wellcome Trust has. So there's a lot of nations that don't have the resources to stand up. Coalition for Epidemic Preparedness Innovations. Yes, excellent. So a lot of countries don't have the money to stand up pharmaceutical infrastructure for pandemics, even though it's been a big risk, but the United States has. So that's why we were able to do everything out of Health and Human Services and the Department of Defense, which, it was Operation Warp Speed, but there's also organizations that just do this. So for example, the Biomedical Advanced Research and Development Authority is generally where the money goes in order to initiate all the contracts for pandemic response. National Institute of Health, of course, where Tony Fauci works, and then DOD, because they do a little bit of everything. So CEPI is organized differently, but they entered into I believe it was a couple $100 million contract with Mrna in January of 2020. So very, very early in order to get a vaccine going. And that's the source for a lot of the European vaccines. So CEPI serves sort of as an intermediary, an investor, and a broker for distributing it at the highest level. And then, of course, the way public health works in our country, it's very fragmented, and it really doesn't work the same way from state to state and city to city and county to county. Europe's the same way. It's very, very fragmented. There was a brief explanation of Germany. They're having some problems, and part of the reason for that is the nation of Germany is basically divided into 8 different districts, and each district runs their own public health program. So, so they've got to, figure all of this stuff out and operationalize it quickly. And in the United States, we've made investments so that public health departments actually have been practicing doing all these drive-through pods that we're seeing now. So drive-through testing and drive-through vaccines, that's something that public health, they go out and they put on drills and exercises where they practice this a couple times a year.
So yes, there are a lot of reasons why different nations are at different places in their vaccine rollouts. And it's kind of unique for each country, how they're going to organize it, how they've planned for it in the past or planned for it now, and how their public health systems work. And Nick, since you're Maricopa, I'm guessing that you have done a million of those planning exercises for exactly this moment.
We have, and I work for Maricopa County now. I worked for the state before. Those exercises, as well as they made us feel, really still are exercises. And so this has been a different beast. And I would also say that, I think where we are today and where we were at the beginning of kind of vaccine preparedness for rollout is a little different now that we have kind of a clear federal united response. When Tim was talking about those 8 different districts in Germany, I thought about, the 50 different states we have in the US. And, in Arizona, we're lucky that we just have 15 counties. When you start looking at city health departments and you look at states that have, hundreds of counties, this is a process that I believe, and this is Dr. Nick Staub, not Maricopa County speaking, I believe that we're in a better place today because we have a more united national federal plan as to how to get vaccine out. It's been a great support to the state of Arizona and to Maricopa County just to have that general push to get this vaccine out. So I'll leave it that there.
All right. Well, there is one more question that just popped up in the Q&A box, and it is, are we nearing the end of the pandemic or are we expecting a 4th surge? How should we prepare ourselves?
I mean, we've done this before, so you know how to prepare. You hopefully by now know how to prepare yourselves and how to start acting if cases start trending upwards. Where we are seeing a slow uptick in the 7-day average for cases at the moment, which, it's relatively early. That doesn't mean we're going back to a massive surge, but it does mean wear your mask and wash your hands and keep your 6 feet away from people and
get vaccinated.
Please, yes, please get vaccinated. We're not out of the woods with COVID. And it's going to be a while before we're all the way out of the woods. But that's why I'm so excited to have this vaccine.
And I would just add, remember, just like seasonal influenza has its annual peak and troughs, like that is the natural way that these infections go. So while we're in kind of this hyper intense transmission period of the pandemic, I think we're going to continue to see those case counts go up and down, hopefully never as high as they were, and hopefully the consequences of those peaks as our higher risk individuals are vaccinated, you won't see as many deaths and hospitalizations. And what you eventually get to, and I've been told, and I'm still harping for this reference, but in general, coronaviruses will mutate and change in time until they become more transmissible, just very readily transmissible, but less virulent, less causing less severe disease. And you have to remember, we have a number of garden variety coronaviruses that cause common colds every year, and we don't get excited about them. And so that's hopefully where we're going with COVID. And again, we'll get there faster and more effectively with effective mitigation strategies to decrease transmission, including vaccination.
All right. Well, there are no more questions. We have kind of finished all of those. So unless any of our panelists have anything that they are dying to talk about, I encourage it. I love it. I am obviously, you know, the nerd of education. I just want to know everything. But I am just very thankful that all of you panelists took the time out of your very busy schedules to be here and to educate all of our attendees. I really want to say thank you to all of our attendees for being here and for taking the time to educate yourselves. Maybe figure out if this vaccine is right for you, figure out how to talk to your family members, friends, loved ones, whoever, your dog, I don't know, whoever you want to talk about this vaccine with. I think one of the best things I've heard as a student is you stop replication, you stop mutation. So for those who are worried about mutant strains, I definitely am a big advocate for vaccination. And like everybody said before, again, you stop replication, you stop mutation. We can get through this together if we all just get vaccinated, wear a mask, stay away from each other. But I do really want to say thank you to everyone who participated. I am very, very grateful. And I do want to remind everybody that there is another week of this COVID-19 speaker series. And next week is our final and fourth week. We will be talking about life after vaccination. So talking about, you know, those CDC recommendations. How do you continue to be cautious? Maybe you can't get the vaccine and you want to know what you can do to still protect yourself, things like that. So I highly recommend that you all come to that. And again, I am just so thankful and grateful for every single one of you who was here. If you participated, asked a question, answered a question, everybody, I really appreciate it. So thank you so much and stay safe and healthy out there. Hello and welcome everyone to our last and final COVID-19 speaker series. My name is Erin Krasnow and I am a senior studying biological sciences and I will be your student moderator for the day. Today's topic is life after vaccination. Now, before we begin, we know the topic of vaccination can become very political. We ask that you put your political views aside and just listen to the facts and advice presented to you today. I also want to acknowledge the news that recently came out. The CDC and FDA have advised to put a pause on the Johnson & Johnson single-dose vaccinations. If you have received the Johnson & Johnson vaccine and have any concerns, please contact ASU Health Services or your healthcare provider. We also want to acknowledge that this is a positive that the CDC and FDA are pausing vaccinations. They are putting our health and safety as their #1 priority, and we just want to, again, acknowledge that this is a positive and not so much a negative. Now, for today's webinar, we are going to do a little bit of a mixture of discussion and Q&A, so we encourage you to write any of your questions that you have in the Q&A chat. Now, without further ado, I want to introduce our speakers for the day. We have Erin, Tim, and Anna, and Erin Trahuli is going to go first. So Erin, take it away.
Great, thank you. Thanks for this time. So with the topic of what is life after vaccination, I'll be speaking about some components which I'm seeing, experiencing, and my knowledge of mental health as it relates to how we're kind of emotionally processing life in this current space and moving forward once more people are vaccinated. And as I was thinking about this topic, in lots of conversations, both in my personal and professional life, with students, with colleagues, with teams, with my friends, with my family, there's this collective desire to perhaps like finally hit a finish line, like to read the last chapter of a book and then like close something, and then just like, you know, gallop into this like new space that's completely different. And I think what we're all kind of working through is the reality that is like, you know, you close one thing and then there's another thing open. You close one thing and then there's still another thing open. And so the gradation of moving into a post-vaccination life is actually gray, it's actually multi-layered, it's actually 30 more chapters, which is a lot of things in our life, but that has its own energy to it. That the things that maybe we're excited to do or changing to do means that we're relaxed in a certain way, but then there's residuals that are coming forward with the processing of all the things that we've had. So, I'll give you an example from my own life. Both my parents were higher risk for the consequences of this virus. And when they got vaccinated, I was like super relieved. And I was relieved to get it myself, obviously, but for my parents, I was very relieved. And then I had a kind of different layer of relief when like my core circle, when everyone kind of at least had scheduled. And I didn't really expect to feel like that level of relief in gradation. But through that relief becomes a new step of like, wow, what just happened in the last year? Like there's more freedom to process stuff. There's more freedom to kind of think through emotionally everything that we've been through. And so I noticed that myself. I know with colleagues, we've talked about that. I'm hearing that with students a lot, that just as something kind of starts to close, it just kind of opens up this other space. And so my first message is that I don't think there's really like a finish line. And so just like everything else in life, we've got these little steps. And this is a particular type of stepped process. The second thing I want to say is that stress, which is what I think everyone in the world has gone through, some degree of stress. It accumulates over time, and it is processed over time. And so what we're seeing here within the mental health space and within mental health spaces at a national level is as people start to kind of get their baseline safety remet, there's more emotional processing of what and stress processing of what we experienced in the last year. And so in the last year, immense amount of loss, both grief, whether it be of a loss of a loved person or loss of experience. Grief can be all sorts of losses. A loss of a vision of something, a loss of a expectation, a loss of connection. All of these things are these losses, and over time those accumulate. And so there's this kind of one step in front of the other, and then once there's like a place to pause, those things kind of start to creep back up and kind of come into our existence again. And so I think it is normal to still be processing some responses to something that was last year at this time, or be thinking through, especially as we hit a year, like there's a little bit of an anniversary to what life has been like in the last year. And that's super normal, even though all of us want to be like, wow, why am I still thinking about that? I wish I could be through that. Last I'll say, and then, there's more I can say to this, but just in 3 points, there's no finish line. Stress accumulates over time, and it kind of gets processed over time, especially when we move in and out of new steps. There may be things to process now that we didn't have the capacity to process a month ago, 6 months ago, a year ago, last week. The opening allows for different places to process. And then third, adjustment is really an individual process. As we start to navigate like what we each feel comfortable doing, that might not be the same thing as what our friends feel comfortable doing, or our parents feel comfortable doing, or what society is doing. And so in some ways it still requires each of us to kind of feel individually grounded in what we're ready for. Things that felt super normal all of our life at some point don't feel as normal anymore. And that's justified given the way that we've lived this last year. And so some people may feel comfortable going to a restaurant, but some others may not. Some people, even with vaccination, may be comfortable seeing a group of friends, and others may not. And that is both in thinking of yourself, permission to kind of go in your own pace, but also in your kindness towards others, just recognizing that we're all kind of adjusting and we're all kind of doing our best in that adjustment. And so if you have a friend or a family member or a classmate or a colleague or anyone, your neighbor that's at a different point than you, they just get to be at that point and you get to be at your point. And so there's still a lot of like reminders, I think, in terms of the emotional world of adjusting in a way that maybe not everyone else is, or being in your own space for that. In final, this is a kind of Spanish word, in final, finally, I want to just name, there's some things that we know that research tells us about how we move through stress and how we move through isolation. And that is connection, which is obvious. When the more we feel connected to people, the more we feel seen, and the more we can see others. There's something that is really fundamentally healing about that. It is a stress reliever to feel connected, to have a meaningful time with people. And then the second piece of that is also meaning. A lot of people I've seen kind of talking about like, what is the meaning of all this? And that's really an individual process. But when no one was like, what would be great in my life if I could live through a pandemic? Like no one has invited this into their life, but all of us are kind of sorting out things that we've learned about ourselves or learned about the world or learned about how we were operating before. And all of that has an aspect of meaning, which certainly can help with concretizing what we would want to take out of a situation that we didn't create. And so maybe for some, you've reconnected with people who you were distant to, and you just put more energy into those relationships. Maybe for others, you're being really kind of thoughtful about what you add back into your life. Maybe for some, there's a difference in appreciation of different things, whether it be classes that you like or friendships that you have or what you're studying. All those things can have a different level of meaning. And if you haven't taken some time to kind of think through, all right, 10, 20 years from now, when I look back on 2020, 2021, what do I want to take from that? How do I want to understand myself better? I think that's a good thing to journal about. It's a good thing to talk to friends about. It's a good thing to just process through, because it's going to help you make meaning of this for you now. It'll help you kind of concretize and empower yourself with, okay, how do I actually, with this really shocking, not to be prepared for life, a period of a life, how do I make sense of what I want to learn for myself and how I want to kind of shape this for myself? So connection and meaning, I think, would be two things to kind of consciously continue to put in your purview as you start to kind of take these next couple chapters of walking into life, being vaccinated, life when your family's vaccinated, when your circle is vaccinated. And with that, I'll close for now, but certainly in the future, welcome questions.
Thank you, Erin. Tim and Anna, if you want to add anything to this topic of discussion of life after vaccination, kind of what can we expect? I think Erin obviously has touched very much on the mental health side of things, but maybe more on the logistics side of things, or even just what we're going to see as a society kind of rolling out and starting to get a sense of normalcy again. What can we expect for life after vaccination?
So I think for once, I'm actually going to take off my public hat and put on my historian hat for just a second, because I think it's a little bit useful and connects a lot to what to the things Erin was talking about. You know, this is not the first global pandemic. It's the first one we've had to live through. So it feels like the only one ever to us. But I think it's important to remember that, you know, things may not go back to exactly the way they were before. We as humans probably won't individually, and in how we function and behave as a society, it might not be identical, and that's okay. And it often hasn't been before, but it has turned out okay. And a lot of good things, a lot of good changes have come out of those things. So I think one of the things that may be important to remember is that change is not necessarily bad, and that it's okay if, as we evolve after this, as individuals and friend groups and communities and societies, if we end up somewhere we didn't expect or somewhere that's not quite where we were before. And it's one of the historical lessons that I find hopeful. I hope other people do too. But Tim, you're up.
So that was way better than anything that I have to say from both you and Erin. For good reason. I'm a math guy. I'm a numbers guy. I've been doing epidemiology for a very, very long time. So I too have been studying pandemics, and I've been pretty, locked away in my house, just like everyone else, wondering when this is all going to change and what it's going to look like when we come out of it, and actually trying to propose some solutions for how we can do this the right way. So I have a few observations that I'll make, and I think they're, the way I look at it, they're just sort of mile markers in order to get back to the way things were, or some semblance of the way things were with the new changes. There are some very concrete things that have changed, and there's some mile markers that we're going to see along the way that let us know where we are. But unfortunately, no one, not Tony Fauci, not Anna with her historian background, and not even Erin can say how things are actually going to go, because there are some things that we just don't know. The bit about the Johnson & Johnson vaccine is a great example of this. We think we're on the right track. We think we've got a great piece of technology. We think we've got something that's going to get everyone, a little bit closer to going back to normal. And then, poof, some very rare events happen, and all of a sudden we have to reconsider things. So I think for the first time in a while, I think we've been able to look a couple months ahead. We've really been stuck looking a few days or a few weeks ahead, wondering what's going to happen next. And right now, the mile markers that we have looking forward, I know that everyone's really interested in knowing what's going to happen in the fall, especially since we're all at ASU and we're all here together. Are we going to be back in a situation where there's 50, 60,000 people on campus every day, and we're all in classrooms interacting with each other? And the honest answer is, I don't know. I hope so, but I think that there's going to be some changes that we see. So how do we know how things are going? So the first is, as long as we're making slow and steady progress to be able to do the things that we like to do the most in limited versions, whether it's going out to a restaurant, spending time with your family, being involved with study groups, sports, which is a big interest of mine. I love ASU sports. As we start to do these things, everyone's going to have to prioritize what's the most important thing to do now, whether or not it's safe to do it. If you've had a vaccine, and it's been a couple of weeks since you got the vaccine, obviously, following the CDC guidance, permissions are starting to relax a little bit. So this is all very reassuring that come fall, we're going to be able to have, the kinds of things that we like again. So, Starbucks in the MU, like how great is that? I never thought that I would love Starbucks in the MU as much as I do right now. So we have to watch for this. So we have to watch for whether or not we're making progress in beating this stupid pandemic. I mean, that's really what everyone has been saying since the beginning is we're not done with this until we've beaten the virus. And the things that we have to do to beat the virus now, one is we have to get control of the daily case counts. How do we do this? Testing, isolating yourself if you're not vaccinated. If you do go out, making sure that you're still practicing masking and distancing and all of the other things that you're doing, and being careful about where it is that you go. The next step in that is going to be, of course, getting vaccinated. You can do more things if you're vaccinated, especially if you're interacting with people who are vaccinated too. So as we're watching the daily case counts, that's kind of it. We just want them to go to zero. And if case counts are incredibly low in the fall, then I think we get all of the things back that we like, or at least the ones that we like the most. The second thing that everyone's watching out for right now, other than the vaccination, is of course the variants. And the reason that we're looking at these variants is because some of the new variants are transmitting at a higher rate than the original virus was. So this means that we could lose our progress. So we're just keeping an eye on that. Vaccination is actually the best way to fight the variants. The more people that get vaccinated, the more the variants don't matter because they don't have an opportunity to spread as much as they did. And probably everyone has heard the phrase herd immunity more than they care to. So let me talk about this just for a minute. I got an email or a phone call just last week from the director of the Arizona Public Health Association. And he was like, all right, I really need to understand what this herd immunity is. Everyone throws it around, but what does it actually mean? And what it means is, can we actually get to a point where we can do all of the things that we want to do and cases don't go up again, right? It doesn't mean that we can go do the things that we want to do now. What it means is that, can we reopen Sun Devil Stadium? Can we reopen the bank? I guess it's not Wells Fargo anymore. It's a new bank. But, can we go watch football? Can we go watch basketball? Can we go to baseball games? Can we go to lacrosse games? Can we go to hockey games and have it be okay? Can we be in a situation where you can go into those and they're no longer super spreader events? It's just an okay place to be. Are people going to walk in with COVID every once in a while? Yeah, they probably are. So what's the way to make sure that doesn't become a super spreader event? Well, we have to get like 85, maybe 90% of the people there vaccinated in order to do that. That's really the only way to do it. There's limited information about reinfections occurring. We know that they do happen. They're incredibly rare, but just because you've had COVID before doesn't mean that it's impossible to get it again. It's really just a matter of time. And we're waiting to see, what happens with this virus over time. Remember, we already have 4 coronaviruses that are in circulation on an annual basis that are just part of cold and flu season. They're not as bad as this one, but because they've been around for a long time, people have generally been exposed to them in some combination. And so part of what we're looking for going forward could be a similar situation with this virus. And we don't know what that means. We don't know how bad that would be. Certainly for new cases, some of the symptoms are pretty bad. Of course, for people who are at high risk, the risk of dying is incredibly higher than we would like to see. But even for younger people, some of the other symptoms, the long COVID is a big one that's coming up. Some of the neurological symptoms that are coming up, they're just things that you don't want, even if they're not particularly life-threatening. They're just unpleasant and could have some pretty serious consequences. So we don't want that to happen either. So as we go through things, again, watch the daily case counts, keep an eye on how we're doing there, watch the variants because those are things that could potentially cause those case counts to go up. Pay attention to what you can do in terms of CDC guidance, in terms of social distancing, in terms of whether or not it's appropriate to wear a mask, in terms of when it's appropriate to go spend time with your family and your friends. Gathering sizes are certainly important. We have to do all of those things. And then we'll see. My hope is that by the fall, we can actually open up. I'm actually really concerned right now because I think some of the things that we're doing in this state are premature. I think that what we're doing in terms of opening, the Coyotes to 50% capacity and the Arizona Diamondbacks to 20,000 fans, I think are insanely premature. Arizona is in a race with Florida and Texas to see who can be the most boneheaded in their decision making in ways that'll kill people if they're not careful. But I think it's important that everyone realizes that accompanying this message, there's always a message of individual responsibility. It's in Arizona's DNA to, do some crazy, radical, wild, wild west kind of stuff, and we're not so great at public health. So it's important to just pay attention to what folks are doing in other states where they actually have strong public health programs and a history of taking care of their citizens rather than just throwing the rule book out the window and giving everyone a shotgun and wishing them the best. So there's a little bit of that going on right now too. And so we've got to navigate that. We have to navigate that as a community. So just be calm, be careful, pay attention to what you're hearing from trusted sources, and make good decisions. And if everyone makes good decisions and we approach this as a community and approach this as the community of care that ASU is, I'm pretty confident that the fall should turn out pretty well and we can all go back to the things that are the most important to us. Are things going to be the same again? No, this is going to be a situation that's going to last with everyone for the rest of their lives. And that's just the reality of what it is. So I'll end there, and happy to answer questions or have any conversation if folks want.
Tim, I think there is actually a question that you may be able to answer in the Q&A box. It is there a number of daily case counts that would be optimal to say we're beating the virus effectively that isn't 0, of course?
-1. No, there really isn't. But so the way that the science works on this. Okay, so when we look at the science of this, epidemics usually they go up exponentially, which is what we've seen. When things just get out of control, everything is increasing exponentially. The numbers are all radically going up. That's when things are bad and things become pandemic. When things are dying out, and they generally die out because of immunity, whether it's naturally acquired or vaccine acquired immunity. Doesn't matter, things will actually die out exponentially as well. So this is one important reason why everyone has to take their college algebra class, just so you know exactly what it means for things to go down exponentially. And what they'll do is they'll get closer and closer to 0, but they never quite go away. For infectious diseases, what starts happening when you have really low case counts is things will start sputtering around. And so you don't get these nice smooth graphs. What you get is just sort of jagged things that are pretty low numbers, but they bounce around. And that's because you don't have really population level effects. What you get is little onesie, twosie cases here and there. You know, someone goes to a sporting event, or someone goes to the mall, or, you know, someone goes to a family gathering and they get the whole family sick or whatever. So the kinds of things that you could have 6 or 8 cases emerging from a single case, but it's not just like everyone coughing and sneezing on each other and licking each other and all those things. So, so when you start to see a sputtering effect, that's called, usually that's called stochastic transmission. Mathematically, that's the good sign that things are going well. Of course, we want things to get to 0. I don't think they ever will. You know, diseases very rarely go away once they're as embedded into a population as this one is. But that's really the sign. You can also, like a lot of people also look at the percent positive rate. So when the percent positive test is coming in and it's less than like 5%, that's usually a pretty good sign. That means most people don't have it. People are inclined to, you know, test when they feel sick. So like a lot of times we were seeing 35 and 40% of the cases were testing positive during November, December, January. Things were really bad. So, and this, by the way, this is the reason for ASU's testing program, where we random sample all of you, and we know whether or not you're testing. So please go test. It's really important, because in order to get the university back open again, what the university is doing here is they're looking for a true baseline level of COVID among ASU students and faculty and staff. So I have to test too, just like you all do. And when that number is low, you know, less than 1%, ideally, then that's a sign to the administration that we can start to relax things a little bit and make life a little bit more pleasant for everyone. So keep testing. It's important. It doesn't hurt. We work really hard to make it so you can just spit in a tube rather than sticking a Q-tip all the way into your brain. So please keep doing it.
Can I jump in and just kind of reference something or speak a little bit about one thing that Tim mentioned at the beginning that's kind of a mental health thing that reminded me of? Yeah. So Tim, at the very beginning, you talked about like, we haven't been able to look more than a couple of weeks ahead for a really long time. And I just wanted to kind of underline the emotional impact of that and the exhaustion impact of that. Like our brains are meant to turn off. Like our brains are looking for routine, you know, when, you know, as soon as we can figure something out, our brain's like, sweet, I don't have to think about that anymore. That's just automatic. And then I go do this thing. And so in the last year, we had to adjust into a new space. And then for a good part of the year, there was not an answer about when that would change. And so the constant weekly, monthly adjustment to not having a vision beyond a couple weeks has its own toll. It means our brains were still kind of processing and looking to like turn off at some point. And then maybe at some point, I know for myself, we've kind of got into these new, what does life in quarantine mean? And maybe like our brain shut off a little bit with like, okay, my new routine is I go do this and this and this, but I'm not in my car. And, you know, like we get used to that. And then in the space of like being vaccinated and making choices, we're back into this space of like deciding all the time and being very conscious about what we're doing. And that has its own energy. And so even if we know what maybe life looks like a couple months ahead of now, maybe, we still have to do all the different changes to get there. And so when you said that, it really spoke to like how much energy that takes. And how if we're tired, we're like, I don't know, I'm tired. I'm just kind of doing what I did before. Well, you hadn't done it for a year. And then you're consciously thinking about what you're going to do. And every week that's changing. And so all of that takes energy. And all of that is like on top of everything else you're trying to do, this like meta energy that we're all spending. And so sometimes we forget that like all of that also takes its own, it zaps us. And sometimes we're like, I don't know, I'm so tired, but like, that's part of why we're tired. Even if you've gotten vaccinated, it's the like, okay, do I go get coffee with that person? Do I go get coffee? Do I get coffee with that person? Do I, you know, what am I doing differently now? What can I make a plan for summer? Am I going to class in person in August? Like all of that is like change. And our brains are just kind of looking to shut off again. So maybe we'll get to that point. Or maybe we're like, yeah, no, I'm not going to think about this anymore, and consciously shut it off. But all of that is energy. And I wanted to make sure that I'm highlighting that when we, it's just another reason why we may be tired.
As a human, can confirm. I'm making my first long-term plans that I've made in forever this week. And it is a strange experience to like plan something 3 months out and actually know that it's going to happen. It's very strange when you start doing it, but mostly good, just a little weird. So we have a question in the chat about how long the vaccine lasts. We're not sure yet. We know, I mean, 6 months at least and counting, but it's going to take time to know exactly how long that is. In general, vaccines don't sort of go from like on to off in terms of how much they protect you. So there's a possibility that we may have to get boosters in the future, but if you ask again in a year, there will be a better answer from the people who are very, very carefully tracking the vaccine.
That's a good reminder that we should all get our tetanus shots.
Yes, please do get your tetanus shots. Tetanus is not good. As an infectious disease historian, tetanus is one of the really, really bad ones. Get that one, please.
I'm curious what you as students think about some other schools around the country starting to talk about whether or not vaccines are mandatory. Because lots of vaccines are mandatory, right? Like the MMR vaccine is mandatory to come to ASU. And
we did get a few questions about that. A couple of them I am going to stay away from a little bit, just because I think some of them are more about like, is ASU going to reopen in the fall? More discussing on the idea of like, is ASU going to make COVID mandatory? I thought maybe we could take this time to kind of discuss mandatory vaccines at a university setting, because I think that there's a lot of confusion when it comes to, well, like, can universities do this? I thought like they can't do that, but I do think that some students forget to remember that, like, when I lived on campus, I had to submit a vaccination form and all this other stuff. So maybe if a few of you could touch on that, and then we can see if we can get a few comments in the chat.
Yeah, so there's a pretty long history of requiring vaccines for particular institutions in the US. And there's a pretty there's a pretty long history of both legislation at many levels and court cases around it. So probably most of the schools you've been to in your lives have required some vaccines. MMR is the most common one because measles is so incredibly transmissible. That list sort of varies a little bit depending on whether it's a school or an employer, but a lot of healthcare institutions also have required vaccinations for their staff, and things like laboratories where they work with particular germs often require vaccination for whatever agent they're working with for their staff, which is to protect both the staff and the public. So there's a really long, detailed legal history and social history in the United States around required vaccinations. There are a lot of books about it as well, should you decide you're very interested in the topic. I have that it's that shelf over there is all about required vaccination.
Who wants to come work with Anna?
You get access to all the books. That's the bonus. Do either of you have more you want to add on that, or?
No, I don't. I mean, it's an interesting conversation, right? Because I mean, I personally, I've made a decision to get vaccinated as soon as I possibly could, and I encourage people to do it. The risk is minimal, especially relative to everything else. But it's an interesting question that we're going to have to answer.
Yeah. There is a student who messaged us saying it would make them feel more comfortable. I think as a student myself, hearing some feedback from other students, the consensus is it would make us feel a lot more comfortable. I think ASU has enough 300 people, 400 people lecture halls that when you're sitting 2 inches away from somebody, knowing that that person has to be vaccinated would make a lot of us feel comfortable.
Right. We sort of have a unique problem being like the largest university in the galaxy. So a lot going on here.
Yeah, I mean, I think that there are going to be a lot of conversations between students about vaccination, and in communities themselves about vaccination as well, for people to figure out what they're comfortable with, whether that's about university directives or just community norms in groups of friends, right? And that's going to be kind of a long social negotiation process, I suspect. I too got vaccinated as soon as I could, partly because I want to see my parents. I haven't seen my parents in quite a while and I miss them, but I have to get on a plane to go see my parents. So got to get vaccinated before I go near the 70-year-olds after having been on a plane. And that, it was pretty clear in my family that in order for me to see the older family members, I really had to get vaccinated. There just wasn't another option. So it's kind of a family standard that if you're going near the people over 70, you have to be vaccinated first. But I imagine other communities will come up with those kinds of norms in the way that my family is sort of intensely enforcing that one.
All right. Well, a lot of the questions that we seem to be getting are more so on like the reopening of campus, and about the decision of mandating vaccination on campus. I believe those decisions have not been made yet. For a lot of students who want to follow that, the undergraduate student government Instagram and Facebook page, all their social medias usually have information regarding that. So if you're tired of looking at your email, you can look at Instagram and Facebook and all those things. I do think one thing that would be good to clarify is if any of you can talk on this conversation that has been vaccine passports. I think everybody hears about these vaccine passports, and if any of you have any insight or clarification you want to give to the community, it would be wildly appreciated for sure.
Yeah, we can talk about that a little. Anna, you want to go first?
Sure.
I mean, we've talked about this a lot, and surprise, surprise, it's kind of a controversial topic.
Just a little bit.
A little bit. So talk about it. That's what people want to know.
So, immunity passports and vaccine passports are not a new concept. In general, we mostly do things like immunity and vaccine checks for crossing international borders. So some of you may have been to countries where you have to have a yellow fever vaccine to enter, right? Those are really common. And it has been quite a long time since we have had internal immunity passports, since that seems to be the words that we're using these days. And they have had their problems in the past. So it's going to be interesting to see if they even can implement a system like that and how much social pushback there is. As someone who studies both history and conspiracy theories, I will tell you there are a lot of them about immunity passports. I'm sure you're shocked. And also a lot of them pull on 19th century history to make their arguments. So I suspect there will be a lot of people who do everything in their power to opt out of any such system. But we'll see. I suspect that we're going to have to show proof of COVID vaccination for international travel. That would be unsurprising and totally aligned with the current international legal system. And with sort of 170 years of precedent around international movement with vaccination or infectious diseases. Inside borders, it's going to be a bigger fight. So we'll see how it plays out. And Tim will tell you that I am deeply anti-vaccine passport for internal purposes. So
Canada is deeply anti-vaccine passport.
he has had to listen to me have moments. So
yeah. I just think it's really hard to do. And we've watched, so I'm sort of a data wrangler, so we've been wrangling a lot of data from the state health department and other sources for a while. And they stood up their vaccine database really quickly, and largely it was stood up to help people get scheduled for their vaccination. But, people go by their middle names or their first initials or something else like that. And so they change their addresses, and it's just really hard to track people. So if you think of like birth certificates, if any one of you lose your birth certificate and you know where you're born, you can go get another copy because it's in the birth database, and they've been building and rebuilding the birth database forever. You give them $30 and they'll print it out a new copy for you. But I don't think that we're really set up to do that with vaccines right now. So that means that little card that you carry around becomes extra important. But again, there's problems with that. That it's not forgery proof. It doesn't have the same markings that the United States currency does or anything else like that. It's just kind of like a Xerox copied cardboard card that's filled out with pen. So I think that the practical, just from a data perspective, that the practicalities around running a vaccine passport system is going to be really, really, really complicated. And I have a feeling that when people call customer service, they don't always tell the truth about how the thing got broken or when they actually mailed their check in and paid the bill. So there's going to be a lot of negotiation that's going to have to take place. So I would put this one in the category of inevitable outcomes, which is that vaccine passports don't work so great, except in extremely limited situations, which might be things like if you work for a hospital system and you're a nurse and they require it within that hospital organization as part of your employment, then they could require you to get vaccinated again just to make sure that you've done it. And those things go hand in hand. Like requiring people to be vaccinated and prove it also requires people to be vaccinated more than they're supposed to be if they can't prove it. And I just don't think that we're there yet.
every time he says this, it makes me feel better because I have philosophical objections to immunity passports. So, and historical objections.
I mean, someone was typing in the chat that they can't wait to see TSA again, right? Like, do you really think the TSA dude wants to have, you know, someone throwing a temper tantrum because they won't let him get on the plane because they don't have the right vaccine passport with them today?
So I will say, for international travel, I will be surprised if we do not have to prove vaccination. So my mother teaches overseas quite regularly, and she has already said that she's been told she's probably gonna have to bring her COVID card and to like scan it just in case anything happens to it, because she's probably gonna have to prove vaccination to go teach again. So I will say, and Erin, probably you have opinions about this as well. I took photos of my vaccine card because, of course, the minute I got it, I began having intense anxiety about losing it. So if this happens to you, don't feel too bad. Everyone I know who has one has some anxiety about where it is at any given moment. Photographs are the trick. Yep. Or at least my trick for reducing that, but
don't publicize them.
No.
Don't post them on social media.
No. At least they don't have your social security number on them. I would say that we're all going to have new anxieties after this, and I was somewhat surprised to find out that my vaccine card was my new anxiety. Who knew?
Well, thank you both for that insight. Speaking of anxieties, Erin, we had a few questions about how can students deal with new anxieties coming back to campus, if that possibility of returning to campus does pan out as we want it to. How can students kind of deal with those anxieties and mental health issues of transitioning back from online to in person?
Yeah, so preparing for anxiety. I think the first of it is to know it'll come. As you were talking, I was thinking about how students maybe felt moving, like starting college or maybe studying abroad. Like, you're going to go do something that's different, and you're kind of prepping for the energies of that. And so I would kind of put it under the same category. Even if you're returning to something that it's not what you know. And so give yourself the angle of knowing that this is kind of like starting college again. It's kind of like moving somewhere different, all the different energies that come with that. And I think anxiety increases when we don't expect, like, we're angry about how we feel. So like I feel this way, and then I can't believe I feel this way, and then it's like, doo, doo, doo. And so I would just kind of say, like, just expect it. Expect yourself to feel something in some way and to be surprised about something. When you came to college, that was kind of anticipatory, and maybe you just kind of allowed yourself that because everything's new. So just put that hat on. Be like, okay, this is all new again. And when you do that, then at least you're going to have energy, and it's not going to be then judgmental energy in this too, because that's what increases anxiety. It's like, I feel this, I can't believe should I feel this? How do I stop feeling it? Like, that's the part that starts to accumulate. I think that I've returned to kind of some foundations about stressors and stress cycles and how they're different, and how there's all this, there's something that's a stressor in the world. And then there's a way that our bodies respond to that, and that's our own stress cycle. And so our stress cycle is emotional, but it's also biological. And so it's like that core part of us that's like preparing for something dangerous. And so our body like responds to that and does what we kind of ask it to do. And then it needs to calm down. And so all of us have had different stress cycles in the last year because we're preparing for things that are anxiety producing or unknown, or we're having a response to something. And that just requires a continual pathway of completing that stress cycle. And so some core things that actually help our body to like work through that energy Exercise, that's why like walking, running, any sort of physical activity actually releases the stressors that are kind of moving through our bloodstream in that. Connection, connecting with someone, laughing hard with someone. When we're laughing, like our bodies can only be stressed or not stressed. We can't like coexist. So laughing is like telling your body you're safe enough to like have a good belly laugh. Those are things that help. Being creative helps. So anyone who has a creative hobby or started a creative hobby, those things help us to complete the cycle. Naming how we feel helps us to complete the cycle. Crying helps us to complete the cycle. Hugging for 20 seconds, kissing for 6 seconds. Those things actually physiologically help us to complete the cycle. Of course, the hugging and the kissing would be with someone who wants that. So, someone you feel safe with, who would welcome that connection. But so in terms of moving into anticipatory energy, I think recognizing that your body is going to need to complete a lot of cycles of stress and just making sure you're kind of locking in on something to help that relieve. You need to kind of readdress that if you start to have some changes in your sleep or in your eating. Those are our body's signal to be like, okay, I'm a little overwhelmed here. And so if you notice that like you're waking up in the middle of the night, difficulty sleeping, difficulty getting out of bed, not enough sleep, those things are your body's signal to tell you that like time to like get some better habits to like complete those stress cycles. So I feel like I answered your question. Is there anything else in that you'd want to know?
Nope, you did more than I think a lot of people have explained for sure. Well, if there are no more questions, and Anna, Tim, Erin, if you don't have anything more to add, we can go ahead and wrap up.
Just hang in there. I think we all want the same thing at this point, which is to get back to it. So just hang in there and look forward to seeing everyone in the fall.
I realize I have one little plug to do for 30 seconds. You probably all received an email about a new expanded service for counseling. And I felt it was really important to have that up as soon as possible. And so we really pushed for this to be available in April because we know that all this change is doing a lot to us in terms of our mental health. And so for students, it's never been easier to speak with a mental health provider. It's as simple as a chat, as a phone call. You can do that as many times. There's more information. I know at the very beginning of the meeting, there was a website link, and I know you all received an email as well. So I think you received an email. There's different emails going out in the university. So my message would be permission to speak with a mental health provider, even if it's for 15 minutes, even if it's a short period of time. That's what it's there for. And more of us than not may find it beneficial just to kind of name something or process something or talk through something. And so that's what we're here for. It's available anywhere in the world. There's multiple languages that can be supported in that. And if you are moving to a new place where there's some stuff to process, we're here. So reach out to us. We'd love to schedule some time with any student.
All right, well, thank you all. Thank you especially to our speakers for taking the time out of your busy schedule to come here and educate us and just talk to students. I think everyone, including myself, like I feel a lot better about transitioning back to, an in-person fall and all this other stuff after this conversation. I also want to give a huge thank you to the Student Health Advisory Board at ASU. If you don't know, this is kind of the platform under which I did this. The Student Health Advisory Board is a branch off of the undergraduate student government that I am a part of, and they gave me kind of the courage and platform to be able to host and put on this COVID-19 speaker series. And I really want to give a big thank you to Philip, who is gone right now, and as well as Rachel, because without either of you, none of this would have happened. And I am just so appreciative of all the help that both of you have given to me and to the community and to the students to educate and spread accurate information. And we just hope that all of you learned a bit more about COVID-19 and that you feel safer and better about working towards a healthier community. Thank you again, and remember to get your vaccine and to follow CDC guidelines. And if you have any questions at all, there's tons of resources at ASU that you can use to get those answered. So thank you again.